Tendolkar, do you know I am MS General Surgery? He was houseman. I was registrar. So every alternate sentence, Tendolkar, do you know I am MS General Surgery? I said, in KM, you throw stone anywhere, 5 MS General Surgeons will fall down. So to whom you are talking that I am MS General Surgery? Sir, permission, Deko. Okay, so we are going to discuss now X-ray chest. It was supposed to be a talk, which I have taken permission not to convert from a talk to convert it into a interactive session. Now, for your knowledge, my official talk has already been circulated, I am told, on your WhatsApp group. Am I right? So it has a huge list of what to talk in an X-ray chest. So from that, I have come down to this very extreme basic CTR. Number 2, rather than saying right heart border, left heart border, same thing with ECG also. Rather than talking about waves, then PR interval, then R, then QR, like that, you can talk chamber enlargements, which becomes very easy. My dear, if you can't see, you can sit next to Durga. Durga, na? So it becomes very easy. And then, of course, as I have been telling you since morning, not to forget the lung fields. So let us start with various X-rays. First X-ray, please. Chalo. Patel Sahib, mic in your hands. Choice whether to sit down or stand. Are X-ray? Yeah. This is the order I have already provided. All of you start thinking, huh? Same time.
Directly start with cardiothoracic.
I told you, no. So well centralized, frontal view, hard plate. Now it is understood.
So
There are 2 ways of X-ray. Detail will be in long case. But suppose it's a short case or spots, you are not supposed to start all those things. Quickly come to rule.
So cardiothoracic ratio more than 0.5.
So more than 0.5 is 100 also. Can you, since morning, Prasanna has been putting hands and so you are, nobody is going to catch you on 55% versus 60%. So don't waste time. Quickly come to some answers.
60%.
60%. So which conditions CT ratio in the worst pathology will be still 60%? Stenotic lesions. Remember, in the volume overloads, the CT ratios increase massively. And another kind of overload is stenotic with regurgitant overload. There was one villain called Ajit. He used to dip his opponents in liquid oxygen. Liquid तुमको सांस लेने नहीं देगा, oxygen मरने नहीं देगा. That was the famous dialogue. Tambi, understood Hindi? Huh? So MSMR, ASAR, TSTR are the worst lesion. The stenosis doesn't allow the chamber to empty and regurgitant keeps on filling it. Okay? So if it is 55%, what thought comes to your mind?
Might be a stenotic lesion.
Must be a
Stenotic.
more likely to be a stenotic lesion. Very good. Understood this? So start talking, thinking. My friend, I always remember him, R. Ravi, head of the Department of Radiology, my contemporary. He used to say 5 minutes for occipital lobe and 5% for occipital lobe and 95% for temporoparietal lobe. The problem is you spend all 100% time in occipital lobe, in reading. Reading is over. 2 minutes. Now everything is temporoparietal. Okay? Chalo. Chamber enlargement.
RA is enlarged, right?
RA is enlarged.
Yes.
Why you call it RA enlarged? Prasanna, 2,000 rupees.
Because right-sided shadow is bulging.
So right heart border is seen beyond the
hilar.
beyond the lateral border of spine.
Spine.
And the official definition is half the width of the spine.
Fine.
So
Yes, sir.
you take half the width. Beyond that, see, that's why it is called right heart border is enlarged. Go ahead. Second chamber.
Left atrium is also enlarged.
Why you say so?
There is shadow in shadow.
So what is the other shadow in shadow? Any other word for that?
LN
Double
double check.
atrial
Shadow.
shadow. And very commonly asked question is, which one is RA? Which one is LA? Out of
Outside. Inside is a LA, outside is RA.
two shadows, which one is LA and which one is RA? So the inside one is
LA.
LA. Any other feature of that shadow?
It bends before joining the diaphragm.
It doesn't touch the diaphragm. Even if it touches the diaphragm, it is always at acute angle.
Acute angle.
LA enlargement, pathology. While the RA shadow always will, does this have
Carina.
where is the cursor? So what structure is here?
IVC.
Anatomically,
IVC.
IVC. So RA will always touch the diaphragm at
Merge with the IVC
90
shadow.
degrees. Okay? Very good. Third chamber is
LV.
RV.
RV.
I have written
RV
down
enlargement.
RV. Go ahead. RV. What is the problem of RV? In a PA view, RV enlarges
Anteriorly.
anteriorly. So in a PA view, will you see RV enlargement?
No, sir.
No.
Not well.
Understand? Unless it's the extreme RV enlargement is not seen. Another thing we forgot. LA. Which other part of LA you can see enlarge? In this case,
Appendage.
Appendage.
LA appendage. LA appendage is thinner wall.
Yes.
It is free in the pericardium. So LA enlargement, appendage enlargement is the earliest to occur. While body is a thicker wall, diaphragm below, bronchus above, vertebra behind, ventricle in front. So it is very tense and bound. So LA appendage, which space you see?
Left heart border.
First space, knuckle, second space,
P.
PA, third space,
LA
LA
appendage.
appendage. Very good.
Yes.
So do you see LA appendage?
Yes.
Where is LA appendage?
That straightening
LA appendage should have been
straightening of the border.
green color. Can you see my pointer?
Yes, sir.
I am not seeing my pointer.
Yes, sir, we can see.
Can you see this?
Yes. Sir.
Yes.
So this is not LA appendage enlarged. So LA body enlarged, LA appendage not enlarged. Possibility?
LA clot.
LA clot.
Clot might.
LA appendage clot forms first. Any other possibility? Post
CMV.
Post-
Post CMV.
CMV.
closed mitral
Valvotomy.
valvotomy. So immediately look at the ribs. Do you see any rib crowding, rib fracture, callus, etc.?
No, sir.
Okay, remember, whatever you speak, immediately look for corresponding.
Cool.
Anesthetist say, we have disconnected the lung. Still you see the lung moving. So always keep on. Perfectionist says, I am on full, but still you see the RA full. So immediate correlation is the answer in cardiac surgery. Remember, sir is constantly checking what bad I am talking about anesthetist. So whole idea is constant counter checking. Remember. Third is
LV.
LV. So what do you think the ventricle?
LV kind of apex is
This
there.
apex, you
Is
feel,
not going beyond.
you see any part of the ventricular contour below the dome of the diaphragm?
No, sir.
Not much.
No.
Okay. Remember, Prasanna passed a comment. Everything cannot be seen in one investigation. That's why we have to do multiple investigations. If everything was seen in one investigation, how many investigations we would have done? If all the treatment was taken care of in one drug, how many drugs we would have given? One drug. If one operation did all sorts of problems, how many operations we would have done? One. Understand? So remember, so don't have to insist that everything has to be seen. Not necessary. Another chamber is aorta.
Aorta.
What do you think about the aorta? Knuckle is just
Knuckle,
seen
left side. On left
or
side.
very prominent.
Um,
There is no definition.
Hmm.
So what do you
it's,
think?
It's seen, sir.
Is seen, not prominent. So what is the conclusion? Aorta not prominent. Which diseases, severe diseases, does not have aorta prominent? Sorry? Sorry?
Mitral stenosis.
All stenotic lesions, while left-sided pulmonary stenosis also, tricuspid stenosis also will not have. Correct? No volume overloads. No aortic regurgitation. No coarctation of aorta. What about ASD, VSD, PDA?
That would be small.
Sorry?
Aorta would be small.
In which?
ASD.
ASD and VSD.
PD.
Okay? So now you have got a case in whom LA is enlarged, RA is enlarged, cardiomegaly of 55%, pulmonary segment is full, just see that, and aorta looks to you normal. So what do you think is your diagnosis?
Mitral stenosis.
Mitral valve disease.
Disease.
To be very particular,
Precise.
mitral valve
disease.
disease. Now if you are told this is a patient, say 65-year-old, and diagnosis is mitral valve disease, so what additional thing you will see and report to get extra marks? Remember, practical exam is a constant comparison. The earlier student is Siddharth and next student is somebody else. Everyone will constantly compare with Siddharth and you will unnecessarily get bad marks.
As the
Understand? You may be good, but वो तो उसने अच्छा बोला.
as the LA is enlarged, there is a splaying of carina. And
I'm saying we are mitral stenosis is over. I agree. Anything extra about the pathology of
lung fields.
Pulmonary artery, features of pulmonary artery.
lung
hypertension.
fields? We are not come to lung fields yet. In calcification, very good. Of what?
Unless mitral.
Ma-
unless-
Mitral valve,
Endless.
annular, cusp also.
Cusp.
Understand? So these are the extra points which you will get. Now come to lung fields. What about lung fields?
Plethoric field.
Lung fields
Plethoric.
in valvular heart disease, you don't use the word plethora. You say
Hyperemia.
pulmonary
Hyper.
venous
hypertension,
congestion. So what are the types of venous congestions you know? Mild, lower lobe. Moderate, what happens? The venoconstriction occurs and upper lobar veins
Dilate.
become prominent. You can beautifully see this.
Yes. Cephalization.
Cephala.
Okay? Or antelope sign, whatnot signs.
Antler sign.
Third is
Uh,
lymphatic congestion in the form of
curly line.
Curly.
peribronchial cuffing.
Cuffing.
Curly lines A, B, and
C.
C. And last is effusions. So you immediately report whether what kind of congestion is this. Okay?
Venous congestion.
What do you think will be the complaint of the patient?
Breathlessness.
Why you think so?
Because there is venous congestion.
Very good. So venous congestion decides the breathlessness. I'm very happy. Very good. Excellent. Chalo. You want to appear again? Fantastic. I appreciate that. You are from Poschim Bongo? No? Same format.
So CT ratio is around 50%.
So which, just now we have discussed, CT ratios 50%.
Yes.
Do you know severe disease but normal CT ratio? Absolutely normal. Prasanna's those two hands will be still 50. Very severe. Aortic stenosis. Remember, pulmonary stenosis.
RA is not enlarged, sir. LA LA is in
RA is not, right heart border is not prominent,
prominent.
is
sir,
prominent,
sir.
but what but? Right heart
Yes, sir.
border is
Yes,
prominent,
yes,
but LA is not enlarged.
yes.
Very good.
Uh,
RV,
RV type.
RV type of ventricular
sir.
contour. The apex can
Yes.
clearly be
Yes,
seen
sir.
above
Below
the dome of the
Yes.
diaphragm.
So RV type apex, LV is not enlarged. Aorta, aortic knuckle can be seen.
Kidhar? Hardly.
Hard,
Okay.
sir. Yes, sir.
But
Pulmonary bay is full
pulmonary bay, pulmonary segment.
segment, sir. Sorry.
How can bay be full?
Yes.
Bay is the adjective of pulmonary segment.
Pulmonary segment is full, sir. Lung fields are oligamic, sir.
No, perhaps because of too hard a plate.
Yes.
See this?
Yes, sir. Yes.
So what is this condition where the heart is not large? RA is prominent, MPA prominent, but LA not prominent. Previous case, same, but LA prominent.
Pulmonary stenosis, sir.
Atrial septal defect. Pulmonary stenosis is correct if you see the lung fields are clear. But if lung fields are plethoric, the
Then
diagnosis is
ASD.
ASD. Which ASDs you will have CT ratio of 65 to 70%.
Ostium primum.
Where the shunt is more, correct? Shunt is more,
Yes, sir.
volume is more.
Yes, sir.
So what are the conditions where shunt is more?
Ostium primum with
So see, these
cleft
are the
AML.
people who block your temporoparietal lobe. What
Cleft.
Karan was doing to that girl.
Cleft AML, if there's a
So
associated
MR.
MR is there.
So other causes of MR will give you to same problem?
Yes, sir.
Yes. So what you will say second cause? Lutem-Becker syndrome. Okay?
Yes, sir.
So remember, so these conditions, and don't forget multiple shunts. So these are the conditions where ASD will have a more than 65% CT ratio. Okay. Thank you. This is a bad one. Yeah.
Sir, CT ratio is approximately 80%.
So almost left side, just couple of millimeters to touch the wall. Right side, just a couple of millimeters to touch the wall. And we have already discussed.
Yes. Sir,
Right heart border, what do you think?
sir, right heart border is enlarged.
Right heart, extremely prominent by any definition. Right CT ratio people talk about. Even the right CT ratio is almost 90%, right CT
90%.
ratio. That big is the right heart border.
Yes. Sir, the apex is
Next is RV,
RV.
then LV. What about
RV
aorta?
apex. Aorta is
For such a huge heart,
aorta is
aortic knuckle,
not visualized.
first space. By the way, examiner asks you to mark the space. How do you count the space? You're supposed to go to vertebra, and from there you trace the rib. So first rib, second rib. So this is the first space. So such a huge heart, such a small aorta. So what disease is almost unlikely in this case? AR with AS, unlikely. Then MPA segment,
MPA
see this MPA segment?
full, it is full.
Aneurysmal, correct? So what do you think about the pH? Must be very
Very high.
severe, very good. And this shadow is merging with, this is first rib, second rib, third rib. So bring it
Fourth.
medial. So this MPA segment shadow is merging with this shadow, LA appendage.
Also prominent.
And this right heart border, sometimes LA goes all the way and forms the right heart border. Any other method of judging the LA enlargement? LA body is enlarged, LA.
Lateral.
No, same X-ray.
Sir,
नहीं
splaying,
नहीं सिद्धार्थ जी, आपका ज्ञान एकदम, सॉरी,
Displaying of Karana.
उसने बोल दिया कराइनल एंगल. सो हाँ, यू कैन सी परहैप्स लिटरली इमेजिन. ये लाइट बंद कर सकता है क्या? दिस लाइट, ये लाइट. सो दिस इज ट्रकियल शैडो एंड perhaps carinal angle. Yeah, I can see from me it is, yeah, perhaps this is the carinal angle. What is the normal angle?
7.
65 degrees is the normal angle formed by 25, 45. So 70. So if carinal angle splaying of carinal angle. Anything else can happen in aneurysmal LA. This is the example of aneurysmal LA. Anything else can happen to the bronchus? अरे यंद्रिये बेड़ा बेड़ा लाइट बेड़ा. हाँ, they are worried. तुमको कोई पिंच करेगा, he is worried. So you put on the lights for safety. Bronchus can get compressed.
This name.
Understand? So remember this. DD?
Pericardial effusion.
Very good. Pericardial effusion. See the narrow pedicle, the top, absolutely narrow pedicle. So pericardial effusion. And in the olden days, what we used to do in the absence of echo? By the way, echo came full swing only in 1985. Our early days were on X-ray, ECG, X-ray, ECG, ECG, X-ray, auscultation. We take the patient to, very good.
Next.
First, patient in upright position, and next X-ray in supine position. And if the root, the pedicle becomes widened, then it is pericardial effusion. Very good. Third DD, large heart. Third DD, multivalvular. Number 2, Epstein's.
Epstein's anomaly.
Don't forget Epstein's anomaly. Same features you will see. Only thing, LA won't, because of the ASD, you won't be able to see LA. Otherwise, ditto, all will be the feature. Very good.
Cardiothoracic ratio appears to be about 60%, sir.
Don't say appears to be, is.
Yes,
Nobody is going to catch you. This is not examination of law.
it is 60%. The
Loudly or
cardiothoracic ratio is 60%. The RA is prominent.
right heart border
Right
is
heart
prominent.
prominent.
And if you see, trace it, see how it is meeting?
It's acute angles.
Acute angle. So likely to be
Left
aneurysmal LA. What is very glaring
There's a valve present, sir.
is the
It is
post-operative
post-operative.
X-ray
Yes.
through what?
It's a
Mix-
midline sternotomy.
Median sternotomy. Very good. And there is a
Valve present.
prosthetic valve. Bioprosthetic valve?
No, sir.
What is the hallmark of bioprosthetic valve? 3 struts. Don't just say struts. 3 equidistant struts will be seen. Then this valve is in which position?
Mitral position, sir.
Mitral position. Because if you draw an imaginary line corresponding to AV groove,
Yes.
AV groove. So where it starts? Right cardiophrenic angle
Yes.
going to anterior end of third rib. That is LA appendage. So draw an imaginary line. So this valve falls inferior to it. That's why this is a mitral valve. Can you appreciate this? This is a hook. Okay? This is a Medtronic Hall valve. What else you will report? So this is a prosthetic valve, has come for X-ray. Stop looking. What's your name, dear?
Jaidev, sir. Jaidev.
Jaidev.
Yes.
From Jaideva.
Yes, sir.
Fantastic. The Jaidev Square. So Jaidev Square, stop looking. Why a patient has with a prosthetic valve, X-ray has been recorded.
We want to look for. We might be thinking about any stuck valve, sir.
Stuck valve. Anything else?
Displacement.
So
of the-
prosthetic dysfunction.
Yes.
Okay. Anything else?
Please.
Can it be a routine follow-up?
Yes, sir.
Routine follow-up.
Yes.
And routine follow-up as per the norms, X-ray is to be recorded.
Yes.
Possible?
Yes.
Very good. So is this routine follow-up or stuck valve?
Routine follow-up, sir.
Why?
The valve is open in position, sir. It's not closed.
You can see the open disc. Don't try to see many things. You can see open disc opening and closure in
No, sir.
fluoroscopy, not on X-ray chest.
Yes, sir.
What is the difference in X-ray with stuck valve and a routine follow-up?
Pulmonary
Pulmonary,
congestion.
venous congestion.
Yes.
So you look and opine. Don't get scared. In MCQ only, your answer and the examiner's answer has to match. In MCQ, you can take full 3 hours to answer one MCQ. And you can do toss and tick A. And if A is the answer, you will get 1 mark. Full mark. But in practical, if you take so much time to answer, and even if you answer correctly, you will not get any point. One of the vendor at the IACTS conference was telling, sir, please tell your students, our valve is the best valve. I said, that is the concept in practical exam. You can tell any valve, but tell why you are using that valve. You can tell St. Jude, you can tell Medtronic, you can tell Onyx, whatever valve you want. Who is going to hold you? But you must know about the valve. The valve which you are implanting. Arey, kya ho raha hai? They get excited by darkness. Huh? So always look at the lung fields.
Yes.
Remember your lifetime, any post-operative X-ray, demand to say, see pre-op X-ray. Pre-op X-ray shows this patient had a CT ratio of 55%. And now this is the X-ray. Understand?
Yes.
Diagnosis different. But pre-op X-ray, same. Post-op X-ray, same. Not to worry about.
Yes.
Okay? I am asking you, pre-op X-ray, 60%, post-op X-ray, 50%, post-op X-ray, this. Possibilities.
It's possible that there's a pericardial collection, sir. Pericardial
Because
collection.
Manpreet said pericardial collection and you are echo of Manpreet. Manpreet, interestingly, never used to answer when she was candidate. Now she is answering because blood flow to carotid. Just now you said no stuck valve,
Yes, sir.
but stuck valve can increase the CT ratio immediately?
No, sir.
Nahi. So, possibility? Loudly. Development of other valvular affection. Third possibility, mitral valve in particular, well known for that. Development of late left ventricular dysfunction for not because AML, PML not well preserved. Remember. So number one, just now sir said no, Talk like a consultant. Say, can I have a pre-op X-ray? Not available. Doctor, answer on this only. So could be the same. Number two, additional valvular affection. And looking at the right heart border, the way it is, most likely to be tricuspid valve affection. Thank you, Jayadeva.
Thank you, sir.
क्या हो गया? Can you see?
Yes, sir.
You can come in the center.
Can-
Let us all see you well. She wants to be next to Manpreet, so Manpreet will keep on prompting. Spot diagnosis.
So,
What is that? Radio opaque
so it's a Star Edwards wall.
Star Edward
wall in mitral
Hallmark is-
position.
Hallmark is
The ring
hallmark is of Star Edward.
ball and
Can you see the
Cage.
ball?
cage.
Rib cage.
Uh,
Rib cage.
Yes,
Okay.
sir.
So this is aortic or mitral?
In mitral position, sir.
Why you say mitral?
If we join
Join a line.
between the right
the-
cardiophrenic angle.
To third rib, first, second, third. It is up.
Okay.
And see the cage,
Okay, sir.
ball will go up in the cage, no?
Yes, sir.
So ball is going up. Mitral valve, the ball will go towards
Apex.
LV apex. So
Yes.
this is,
In
aortic.
aortic position.
suppose I twist the X-ray. Still, Dr. Tendolkar, Dr. Shukla, all the seniors sitting over here will say, this is aortic. In the cages. Anybody? Siddharth?
Three
सिद्धार्थ के चेहरे से मुझे मालूम पड़ता है क्या
three-
सिद्धार्थ का विकेट यस वेरी गुड
rib cage has
Excellent,
3 in
excellent.
mitral. In aortic, there are 4.
fantastic thank you very much what's your name dear
Manyas. Manyas.
Manya absolutely give her a big hand If-
Don't know, sir.
Because the ball used to come out in the aortic and they will tie the sutures and slide the ball back in the tree.
officially you are supposed to take out the ball implant the Star Edward valve and at the end don't forget not after coming off bypass ayyo sir ninte body ki vedile unde not like that first only so is to push inside so they were worried see in aortic position your needle constantly comes ball is here your needle constantly comes next to the ball in mitral position ball falls inside and your needle is over here from LA annulus like this. So people were worried. I don't want to cut jokes on that, scratching the balls. So officially you're supposed to take the ball out, implant the valve, and then push the ball again inside. What is historical aspect of Star Edward valve? Historical
one.
importance, 10% of the marks for Viva. Anybody? First valve to be available
To be
commercially.
Commercially.
Of course, there were many varieties of Star Edward valve, and the most torturous aspect of for us in our time was we had to remember which series had what modification. 6120, 6125, 6126 like this. Understand? Best part is after doing all variations, they went back to first one. Can you auscultate it and say this is Star Edward valve? Yes. Who said yes? Yes. How? It is not a click, but sort of pistol shot sounds. Start. Started over. All other valves will be understood. Thank you very much. Very good. You can identify yourself. Your name?
Avneen Tripathi.
Amit Tripathi.
Avneen Tripathi, sir.
Avneet.
Avneendra Tripathi.
Okay, Avneet ji, बताइए.
Sir, CT
All
ratio.
other questions you know. Now this is the straight away. These are called signature wall profiles. Signature means this wall profile means this. You saw first hall, Medtronic hall. Next was star. And this is the third signature profile of the wall. This is bioprosthetic or mechanical prosthesis?
Sir, I'm not sure.
Okay, this is bioprosthesis. And these are the strut. And this is the third strut. So third strut you are seeing like this, not like this, but like this. So this is one strut, this is second, and this is third. And what is the peculiarity of these struts and sewing ring you see? Do you see different parts or one same line continuing like that?
One same line.
One same line continuing like that, which is a hallmark of Carpentier Edward wall. First wall available in market after Hancock was Carpentier Edward wall. Remember. Okay?
Okay, sir.
What is the contribution of Carpentier to bioprosthetic wall? 2 or 3 words. He is the one who found out that glutaraldehyde is useful in not only destroying antigenicity, but preserving the wall and sterilization all in one. Okay? And he's the one who introduced 0.625% glutaraldehyde. Okay?
Yes,
So
sir.
remember this single wire going all around. So this is the annulus, this is the strut. This is the annulus, this is the strut. This is the annulus, this is the strut. So his concept was the ring becomes smaller during systole. So if you have got a single wire going around the strut, it will be compressible. That was his concept. Okay? This is this.
I tell them to always cover the obvious and see the rest. The lung is showing changes.
No, that we have already covered in the previous. Whole idea is do not forget what we discussed earlier. Now we are just concentrating on the intracardiac profile shadows. Okay? You are absolutely right. See this? See this? So sir wants to know early post-op or late post-op?
Sir, this looks like an early post-op film.
Very good. Because
Sir, because
shaking
of
cluster,
uh,
ECG leads, pleural
Yes, sir.
effusion, pleural reaction,
pulmonary
intercostal
venous.
tubes, pacing wires, temporary pacing wires. What is there? Nothing. So most likely to be
Late.
late post-op. How many years late post-op you think? 1 month,
Sir,
2 months?
3 months probably.
Bioprosthetic degeneration will take what? 10 years. And bioprosthetic degeneration results in what? What lesion?
Infective endocarditis.
Stenosis as well as regurgitation. Bioprosthetic degeneration has to do with infective endocarditis. Simple degeneration. Anil Tendolkar degeneration. Because of what? I got infective endocarditis.
No, sir.
नहीं, age. तुम्हारा भी होएगा. Don't worry. तुम्हारा भी time आएगा. Just age. What are 3 degenerations in bioprosthesis? One is atherosclerotic. Okay. Number 2 is standard degeneration, old. And third is immunological degeneration. Okay. Books mention various cells, plasma cells, inflammatory cell, but finally they result in what? Stenosis with regurgitation.
Regurgitant lesion.
Okay.
Point I can also see is that there is unequal this thing. So it is very likely to be a regurgitant jet hitting the right pulmonary veins.
Unequal pulmonary
There is
congestion.
unequal congestion. It is equal to not this one, the previous.
No, I'm just going forward.
Ah.
Chalo. Here you can very clearly see 3 struts. And the
Yes.
entire ring is circular. Okay. So this is Hancock design. So remember, these are absolutely book picture profiles. This is for your knowledge. Manya. Star Edward.
Star.
See the 4 cages, 4 ribs in the cage. Okay. And the apex is towards the LV
Towards
apex.
the
Chalo, baith jao. You want this?
So CT ratio of 0.6, sir. With scoliosis is there, sir. And, right
Go on
heart,
talking. I have put up.
yes, sir. Right heart,
Array.
right heart border is
Everything
prominent.
is array.
Yes.
So
RA is
upper,
enlarged.
upper right heart border is divided into 2 parts. Lower half, upper half. Lower half formed by RA. Upper half formed by
SVC.
SVC, ascending aorta.
Yes, sir.
Correct? So what you are seeing, a soft tissue
Said
density in the
upper part.
upper right heart
Heart border.
border.
Yes, sir.
What is Silhouette sign? Silhouette sign, very important sign. If you can't distinguish a soft tissue shadow from that of the heart shadow, both are in the same plane. So this shadow, can you distinguish it from that of the heart shadow? No.
No, sir.
All that you are seeing, this is air shadow of the bronchus. So it is the same plane with that of the heart. And heart radiologically is in anterior mediastinum. Okay? So what are the possibilities? Right heart, soft tissue shadow. Right half, soft tissue shadow.
So thymoma.
Thymoma, very good. So thymus known to have unilateral enlargement. But look at the lung fields. What do you think?
Pulmonary artery hypertension.
Do you feel these are increased vascularity? Yes or no?
Yes, sir.
So this is basically, see the apex? RV type.
RV type.
So RV type apex. So is it thymoma?
Mostly no.
Unlikely. Your diagnosis is correct. Remember. And if you don't remember, mediastinal lymph nodes. Just like echo finding, if you don't remember, LV function. So remember, mediastinal shadow, if you don't remember, lymph nodes. So third possibility is TAPVC, common chamber. PAPVC joining the, not common chamber, but straight away into TAPVC into SVC. Okay? Don't bother about the diagnosis. More important is the description and arriving at the diagnosis. Since morning, what we are finding? Problem is of arriving at the diagnosis, because supervisor has told you this is this. That is the trouble. Siddharth, आपके लिए 6 sir.
Sir, the CT ratio is around 0.8. Uh, it looks like.
I confess it's a very hard plate.
Yes,
You
sir.
can see intervertebral spaces up to T12 L2.
Sir, RA enlargement is there.
RA enlargement present,
Yes, sir.
but no LA enlargement.
No LA enlargement. Sir. The left heart border is,
Ventricle type,
sir, it's RV type of.
RV type,
Yes, sir.
lung vascularity,
So it's an overexposed, overpenetrated film.
but still you can appreciate
End-on
the
appearance.
end-on shadows.
Yes, sir.
So, no LA, right heart border prominent, RV, lung vascularity,
So there's
ASD.
ASG.
Okay. Now talk extra.
So it looks like a partial anomalous pulmonary venous connection. With...
Can you see a bilaterally prominent soft tissue shadow?
Yes, sir.
I'm sorry about the quality. So this is typically what?
TAPVC.
Snowman's
appearance.
heart.
Yes, sir.
Can we have light, please? Light. आओ
Yes, sir.
तुम्हारे लिए full toss. आओ इधर आओ चौक नहीं लगेगा. He's worried. Typical is to ask you to draw the chambers of snowman. And this is how the cardiac cath wire will pass. This is a faint shadow of the vertebra. And the cardiac cath passes, the guide wire passes like this. So you are supposed to now tell who is what where.
So this is the guides are entering through right femoral vein and then via.
पीछे ले सकते हैं? Ah, we can move the board. Maybe mad. Too much of food. Muhammad. तू बोलो नहीं उधर लिखते जा. Femoral vein इधर आएगा क्या? हार्ट के नीचे. IVC. हाँ. Very good.
Through IVC then entering the RA.
Very good.
Then through the RA.
What structure goes up above the RA, parallel to the vertebra on right side? SVC. अभी तुमको डायग्नोसिस मिल गया ना, तो अभी थियरी नॉलेज. Pulmonary vein. If you write pulmonary vein, वो सांप सीढ़ी के खेल में सिद्धार्थ तू ही बोल. सिद्धार्थ तू ही बोल. This is not for telecasting. तू ही बोल. तुम ही बोलो. If he writes pulmonary vein here after SVC, that snake and ladder, where this fellow has gone? 99 to 10, 0. Innominate vein. Which innominate vein? Single innominate vein. Ayo, single. My God.
The left side.
Left innominate vein. So Siddhartha says innominate vein and Durga says left innominate vein. Whom should I give more marks?
The left.
Durga. Then bolega, Durga is from Sion Hospital. Sir was in Sion Hospital. And sir is anti Uttar Pradesh. Yogi against Yogi. That's why he harassed. This is how you rationalize your failures. Believe me. Examiners are extremely nice and fair. Okay. Innominate vein. See, she is trying to protect it. Vertical vein. You call it LSVC? No. You call it vertical vein. Very good. LSVC kya? Vertical vein. Next.
Then the common chamber.
कॉमन चेम्बर किधर रहेगा? हाँ तो इधर हॉरिजॉन्टल ना, दिस इज कॉमन चेम्बर. और छोटा लिख, बहुत बड़ा लिख रहा है. हाँ they don't know that whole world is seeing through that. Very good. And ये क्या है? हाँ, वो जो पल्मोनरी वेन में उधर घुस गया, वो सचमुच किधर है? Okay, thank you very much. Thank you everybody. आजा बेटा, इधर खींच.
Right click on the mouse. If you right click on the mouse, show pointer options.
Sorry? हाँ.
Okay, no, I'm giving you the point. Oh, now.
Which your decoding. Which is yours?
You right click, you can get all that also you can get
So remember, what have you realized by now? This morning, funding has to constantly be correlated.
Ready, sir.
And you require 5% of logic, sorry, 5% of knowledge, 95%. Remember,
I can
don't
use
jump to
this.
conclusion. Don't look for that.
Pointer. Other than the
Why do you think so?
keep it here.
I have to match up to the master trainer, so you will excuse me. There's some story I have to tell you why this presentation is so called. While I was doing my general surgery, I used to have one algorithm. If the guy is more than 45 years old, we used to order an ECG. Once the ECG comes, you look at the ECG and you say, is this abnormal? Then call the cardiologist. If you say it's normal, then you used to ask, are you sure? If you're not sure, call the cardiologist. If it is sure, then answer is, it is your funeral. Till I started teaching, when I had to tell them how not to be scared of looking at an ECG. We have seen in the past ECGs, no? See a lot of waves. And some of the DNB students have told me that they don't look at the ECG because they think the waves will engulf them and they will drown. So what I'm doing is telling you a system. I'm not going to teach each and every ECG that you're supposed to know, or what each disease, what kind of ECG you will find in each kind of disease. I'm going to show you a simple, structured system to follow by which you will end up with knowing all there is to be known for a cardiothoracic surgeon for the exams too. So as you're seen, when your case presentation is there, they will put up an ECG and you're supposed to tell what you're going to see in the ECG based upon your clinical diagnosis. So you need to know how to read an ECG. Second, you have to evaluate the patient by so many methods. One of the methods is ECG, in which you have to make your diagnosis even more perfect after clinical diagnosis. Third thing is you have to look at the ECG to find out what other investigations you have to do. Fourth, when you're in the ICU, you're supposed to be able to identify arrhythmias so that you can treat it. What is the job of the surgeon? Not just to operate. Most of you are going to go to a single center where you will be the only person, and you have to operate and look after the patient in the ICU also. So you have to be able to identify the arrhythmia so that you can do it. It's an oversimplification. So don't catch me on exceptions to the rule. Just try to understand the concept of the system. Okay. This is an ECG. I'm not going into details of P wave, PR interval, and all that. That you're supposed to know. This is a 12 lead ECG at the bottom. It has got 12 leads. And at the bottom, there is what is known as the rhythm strip. So there are 13 ECGs that you're supposed to look at when you get one ECG strip. The important thing that you have to know to understand how the system is you're going to follow, you have to know that the entire ECG paper is divided into multiple small squares. Each small square vertically is 1 millimeter or 1.1 millivolt. And across, it is 25, the speed is 25 by second. So it is 0.04 seconds, each small square. 5 small squares vertically and horizontally make one big square, which is also seen on the ECG. One large square horizontally is how many seconds? 0.2 seconds or 200 milliseconds. So 1 millivolt will be 10 squares on the vertical axis. You understood this? This is another thing that you have to understand. So the way you're supposed to understand this thing, there's a basic concepts that you have to know to understand how the system works. This is how the lead placements are there. And you see the chest leads and the limb leads are put like that. And this is the direction of the vector. So V1 is put on the 4th right parasternal area. V2 is over here. So when you put all the leads, chest leads, look at the direction in which the chambers of the heart is looking at which leads. You get it? So V1, I'll be using my hands so that you can see my hands to make out where you're supposed to look. V1 is here. V6 is here. And you see here, there, 1 and AVL. 1 and AVL is looking at the LV side. AVR is looking at the back of the heart. The concept of ECG is if the vector or electrical energy is passing, vector is passing towards a lead, it will give rise to positive. So you guys know that. Oh, so let me skip all this. To say that ECG is normal, all these 10 things have to be normal. Did you know that? I never knew till I picked this slide from somewhere. So let's try to see what it is. Dr. Tendolkar has already said the first line. ECG is an analysis of the electrical activity. So the veins and the great vessels don't have any electrical activity. So it cannot be assessed by ECG. You have to use X-ray chest for that. Now, what are the structures that can be evaluated by ECG? Are these 6 things: atrium, ventricle, conduction system, the muscle. Heart is all one big muscle, no? Irregularities of rhythm and axis. I just put axis there because that is one of the things that people often miss when they are reading an ECG. They don't talk about axis. They go directly to chambers. Now, this is the structure. This is the system. And it's very simple. Therefore, I am telling you the system. First, you find out what structure you want to find out from the ECG. Second, don't look at the entire ECG. You look at only 2 leads. Only 2 leads. What I find is when you look at all 12 like this, you don't know where the hell to look for the structure that you're looking for. So look at only 2 leads. And in the 2 leads, you find out the pathognomic thing that you are supposed to see for that structure. Based upon that pathognomic, you can come to a diagnosis of what is the problem with that part of the heart that you are investigating. This is the system. You'll see this coming repeatedly so that you can get the system right. Okay, the same thing. Now, first thing that we can evaluate is atrium. So for atrium, which are the leads that you're reading? 2. Which are those leads? Lead 2 and V1. So again, following the same system, you want to look at atrium. You look at 2 leads only, lead 2 and V1. In lead 2 and V1, we are going to look at which wave that represents the atrium? The P wave. And what is the pathognomic thing that you're going to look for? If you have a tall P wave, it is right atrial, and if it is humped P wave, then it is left atrial. Everybody knows. In V1, what component of what is which atrium? How do you understand this? The SA node starts and the impulse passes from RA first and then goes into LA. So the wave that comes afterwards is going to be the LA. In V1, it is biphasic. So the second part of the wave is LA. Because you're looking at it from V1, LA is activating backwards, so you'll have a negative wave. So if you have a deep negative wave in V1, it is LA enlargement. Simple so far? Now next, what is the next structure that you want to investigate? LV, ventricles, right? Second thing that we can investigate is ventricles. In ventricles, which lead to look at? You look at V1 because it looks at RV, and you look at V6 because it looks at LV. If RV you're looking at it, if you look at V1, the positive or the negative wave will be the RV? Positive wave. Why? Because RV vector is going towards the lead, so it will give you positive wave. So R wave in V1 represents RV, and consequently the S wave, because left ventricle is going in this direction, so it is so very clear. Now to do for ventricle, you're looking for RVH or LVH or both. Now there are so many formulas. I'm not going into the formulas, but standard, some of the things that we use is for LVH are written over here. S wave in V1. If V1 is not very good, then you can do V2. If V6 is not very good, you can look at V5. Simple. If S wave is more than 25 or R wave is more than 25, you're looking at LV, so LVH. Likewise, RVH. So these are the formula. There's so many other ways to do it, but generally you got an idea of the system. This is an oversimplification. So you got the cat's Wetzel also here, right? Next thing you want to do is conduction tissue. The conduction system is there in the heart so that the electrical impulses can pass quickly. There's another problem with electrical conduction. The atria, you're taking a picture of me? I thought you were taking a picture of me. I always do this when somebody is taking pictures of my slides because you're concentrating on looking at taking pictures. You're not concentrating on understanding the concept behind it. And if you don't understand the concept, as soon as you leave the room, you will forget it. So try to understand the concept. I see only a few people nodding to say that they have understood. Rest of the people are blank. That means you are not understood a thing because you're taking photographs. Okay. Conduction system is fast. So if there's a problem with conduction system, it will become slow. First concept. Second concept, the atria are isolated from the ventricle by the fibrous skeleton. Is the insulator. So for the impulse to pass onto the ventricle, it has to pierce the fibrous skeleton. And what pierces the fibrous skeleton? The bundle of His. Only then it comes. So if impulse is passing from SA node through the His bundle and going to the ventricle, you will have a QRS complex which is narrow. To understand this. So you have two different parts of the conduction system, supraventricular and ventricular. If the conduction is slow in the supraventricular, what is the two things that you look for? Supraventricular, you look at PR interval, and ventricular, you look at QRS duration. Right? Now let's take the top one. PR interval is slow. So that suggests what kind of block? It is called heart block. It is called heart block. In the heart block, there are three types of heart blocks. I don't want to go into details of the heart blocks, but just to give you an idea, you can categorize heart blocks based upon PR interval and what is happening to QRS interval into first degree heart block, second degree Mobitz type 1, Mobitz type 2, and third degree heart block, right? This is knowledge based, so you have to read about it, okay? Just to give an example of how you differentiate it, I put this slide here to understand the fourth concept that you have to use for the system. For everything to say that it is this or that, you have to have a set of criteria that has to be fulfilled. Therefore, you will say that this is, for example, sinus rhythm. Sinus rhythm is just not, it looks sinus. It is not like that. It has to fulfill 3 or 4 criteria. If all the criteria are there, therefore you make a system diagnosis of whatever diagnosis. So here also you see at the bottom, there are 4 criteria written. Can you see this? The diagnosis of first, second, third degree heart block is based upon having all these criteria fulfilled. Only then you will say that it is first degree or second degree Mobitz type 1, Mobitz type 2. Okay? You understood the concept? Now we will go to conduction, QRS duration. QRS duration also, after the bundle of His, you have left bundle and right bundle. If they are cut off or short circuited, you will have right bundle branch block and left bundle branch block. So when one of the bundles is blocked, the electrical impulse that is carried through the other bundle has to come to this side through the Purkinje fibers or the muscle. Once that happens, the conduction is slowed. So you will have widening of QRS complex. Suppose an impulse is starting not from the supraventricular part but arising from the ventricular mass, again the QRS complex will be broad. It will be broad. So QRS complex, you have to see whether the QRS complex is narrow or wide. You have to look at QRS complex whether it is narrow or wide. So for fifth concept is for everything that is abnormal, there is a cutoff number. So what is the cutoff number to say, call it wide QRS? 120 milliseconds. So partial RBBB is 110 seconds, but for simplicity, let's take 120 milliseconds or 3 small squares. If you see a QRS complex more than 3 small squares, it is wide QRS. Just remember these words because we're going to use these words for the subsequent part of the understanding. Okay. What I also do in my talks is to give you some way to remember all these things. And the one way to remember all these things is to use mnemonics. So there is a mnemonic over there, William and Morrow. You have to look at it. William has got 2L. So you will see W in the V1 and M in the V6. And the opposite is for Morrow. Okay. Now myocardium. Myocardium, now we are not looking for LVH or RVH, we are looking for myocardial injury. For coronary artery disease, or for any other things where you have Al Kappa, you have got myocardial injury. So for that, which are the leads you have to look for? It is given here. The leads are anterior. I will show you another slide. And this is the what you're looking for, finding that you're looking for. But let's go to the next slide. This is how the ECG looks at all the hearts except posterior wall. Posterior wall is difficult to see on the standard ECG leads. So for that, I've written here, you have to go sometimes to V7, V8, or you have to look for reciprocal changes because posterior is back of the heart. There is no lead looking at the back of the heart. So you will have reciprocal changes in the front of the heart. Okay. Now, to look for injury, what are the things that you are supposed to look for? You have to look for these 5 things. That is pathological Q wave, not normal Q wave, T wave inversions, ST elevation more than 1 millimeter, except for V2, V3 and some of the leads, J point elevation and ST depression with T inversion. And what do they represent? Each of these findings you will get in which leads they are happening. If supposing there are Q waves are in 2-3 AVF, then you will say old transmural myocardial infarction in the inferior surface of the heart. That's clear? Oh, very good. Wow. Let's skip this. There are so many differential diagnoses for ST elevation and ST depression. This is a mnemonic. You will find it anywhere. Third is axis. Now, there are two ways to look at axis. I'll show you both the ways. One is to look at, on the ECG strip, you have 1, 2, and 3, right? They are stacked one on top of the other. So lead 1 and lead 3. So if lead 1, the QRS complex is positive, and in lead 3, the QRS complex is negative, both the thumbs are leaving, so it becomes left axis deviation. If it comes like this, it is right axis deviation. And in this lead, here you can make out the same thing, what is indeterminate axis and which is normal axis. In normal axis, both will be upright. In indeterminate axis, both will be negative. This is a mnemonic just to remember how to do it quickly. A different method of doing the same thing is not given here or is given here. You draw this infamous triangle and you put lead 1 will be here and AVF will be here. This is positive vector and this is negative vector. So in lead 1, you find out the net vector and draw it on this horizontal line. Net vector. You have positive and negative. So you do positive minus negative, then you will get the net vector. The net vector will be either positive or negative. If it is positive, you put it here. So this is 7. And in AVF, again you put the net vector. Here it was negative. So you draw this vector, make a rectangle, and this will give you the exact angle of axis. It's mathematics. I don't have any knowledge why it is like this, but this is it. So this is the way to calculate accurate. But when you present in the case, it is easier to do some thumb rules to find out axis is this side or that side. Thumb rules. That's why you have to use thumb to get it. Why are you sweating? Okay, arrhythmias. Arrhythmias also you have to look at 2 leads. What are the 2 leads? Long lead 2 or long lead V1, right? Because for arrhythmias, the P wave is going to play an important part in determining the arrhythmias, because you have supraventricular arrhythmias and you have ventricular arrhythmias. What differentiates between the two of them would be the P wave, right? So you're going to look at. Now the system to interpret arrhythmias is different from what I showed you till now. So for case presentation, you have to know what chambers are enlarged. You got the system? If you are looking at atrium, you look at 2. If you're looking at ventricle, you look at 2. If you're looking at injury, you look at 2. So easy, right? Now we'll come to arrhythmias. So arrhythmias, you have to look at long lead 2 and long lead V1. You can see. So you can have a rhythm strip. Instead of having all 12 leads, you can have just rhythm strips. That is long lead V1 and long lead 2. So now we'll look at what do you see first in a rhythm strip. For the rhythm strip, you have to ask 4 questions. Is it regular or irregular? First, in this it is. Oh, sorry. In this it is regular. Second question you have to ask is what is the heart rate? How do you calculate heart rate? 2 simple methods. 2 simple methods. Why do you need to know the heart rate? Because for arrhythmias, you have to tell whether it is a bradyarrhythmia or a tachyarrhythmia. Treatment for both of them are different, entirely different. So you have to know what is. Less than 60 brady, more than 100 tachyarrhythmias, right? So we have to know that. But you have to know how to calculate the heart rate. To calculate heart rate, you can have a regular rhythm or you can have irregular rhythm. If you have a regular rhythm, the surefire method to get a more accurate reading is to count the small squares between 2 RR intervals and do 1500 divided by the number of small squares. There's a cruder method where you take big squares and take 300 divided by that, but then you're not as accurate. But the best method for regular rhythm and irregular rhythm is one rhythm strip is 10 seconds. You're part of this curriculum? I thought you're an organizer. Okay, what Dr. Tendolkar has been saying for such a long time, especially to you, is there was a good serial called How to Get Away with Murder. Have you seen? In that, she says one thing: never rob another person's right to learn just because you want to appear to be smart. You got it, no? By prompting from behind, you are trying to appear smart, but you're robbing this colleague of learning something. Because if he makes a mistake, you learned 70% of what you learned by making mistakes. But you don't have enough years in your life to make all the mistakes that you have to make to learn the entire cardiac surgery. So you have to learn from other people's mistakes. Okay. Third thing is there a heart block? All you have to do is find out whether it's PR interval or QRS duration, narrow or wide. And last is you have to find out what the rhythm is. For finding out what the rhythm, now comes the system to follow. So these are a list of ECGs that you should be able to identify. Oh, no, sorry. This is not the ECG strip. This is the ECG strip. Sorry, that was a mistake. That was what I used to look at ECGs and figure out how to make diagnosis. You want to see it again? You want to see it again? This is the way I used to make diagnosis from ECGs before I started teaching. Okay. I like the last but one the best anyway. So there are so many ECGs with diagnosis, but there's so many more. Every cardiothoracic surgeon who is going to handle ICU patients have to be able to identify all these rhythms. So a huge number, isn't it? Let's simplify it for you. Let's simplify it for you. And the simplification of all these things is here. You have to draw this Masterson chart like a chi-squared, whatever it is. On this side, you'll say QRS narrow and wide. Here you'll say regular and irregular. So simple. So what is narrow and what is regular? The ones in blue are the common ones. After that, it becomes a little bit more complicated. If you ask me questions about those complicated things, even I won't be able to give you an answer, but you should at least know the top ones, right? So make for yourself a chart like this. And once you answer in the rhythm strip that QRS is narrow and QRS is, and the rate is regular, I mean, the rhythm is regular, then you have to choose from one of these few things only. No, you don't have to go through the entire list of things, that rhythms that you know of, to find out what it is. You got it? Irregular. Oh, my time is up. Shit, okay. Can I finish the arrhythmia parts? I can. Okay. I'll just explain the concept and I will skip out the rest of the slides. I don't know why I would. So when do you say it is a normal sinus rhythm? You have to have a normal P wave. Second, every P wave must be followed by QRS complex. The regular rhythm must be regular and QRS has to be narrow. Then you say it is sinus rhythm, right? And you can see the ECG strip here. I'm just pointing it out because this same model is going to be continued down the line. You have a normal P wave, not an abnormal P wave. What is abnormal? I'll tell you. Then you have a QRS which is narrow. Every P wave is followed by QRS. The rate is regular and QRS is narrow. This is criteria for sinus rhythm. Now, for example, supposing I take out the P wave completely, then what will be left? You will have a regular rhythm. You will have a narrow QRS, isn't it? But you will have no P wave. What does that make it? Junctional rhythm. In junctional rhythm, you can have P waves. You will not have P waves if the P wave is hidden in the QRS complex, right? Or if it is a retrograde P wave, because it is passing retrogradely, or it is not coming from sinus node, so the P wave configuration will be slightly different. You can have a short PR interval. The normal definition of P wave is not going to be adhered to. It will be too close to the QRS, or it can be after the QRS. So this junctional rhythm. So I've shown it over here. Okay. Now, instead of P wave rubbing it out, I replace the P wave with flutter waves. What does it make it? Atrial flutter. But all other things are going to be the same. QRS is going to be narrow. but there is no P wave. Oh, this is atrial ectopics, right? Junctional rhythm. So junctional rhythm, you've seen this? The rhythm strips. This is retrograde P wave and this is inverted P wave, which is not normal. Okay. You take out P waves and give flutter waves. Flutter waves are sawtooth waves. Rest of it is, only thing it can be regular or irregular, but QRS is narrow. And for every set of flutter waves, there will be a QRS complex. If it is varying blocks, then you will have irregular rhythm. If you have fixed block, flutter with fixed block, every 2 flutter waves will give rise to QRS, then it will be regular. Okay. Fibrillation, you take out flutter waves and replace it with fibrillary waves. This is what it's going to look like. So you just have to look the part before the QRS, which is narrow. And if you see fibrillar waves, which are disjoint and discontinuous waves with very low amplitude, then it is fibrillar waves. So atrial fibrillation, it will be irregularly irregular. Now, come to APCs. In APCs, basic rhythm is sinus. On that, you have to find out whether the ectopic beat is atrial premature contraction or ventricular premature. What do we do? Only the P wave will be abnormal. QRS will be narrow and look exactly like all other QRS complex. Isn't it? And in ventricular premature contractions, the QRS, because it is coming from ventricle, the QRS will not be narrow, but it will be wide and bizarre. And you may not see a P wave. Correct? So this is ventricular. Now, ventricular premature contractions are so many types. You have to understand what are malignant arrhythmias, ventricular premature contractions. What is multifocal? Multifocal, the shape of the QRS complex will keep on changing. Right. Idioventricular rhythm, I told you, simple. It is arising from ventricle, so QRS will be bizarre. Each of the tissues in the heart has got its own automaticity and own automatic rate. The highest automatic rate is in the SA node. Why? Because a higher rate will suppress the automaticity of the junction of what the conduction tissue below that. So the least heart rate is in the ventricle. Now, what I told was supraventricular doesn't hold here, but there are again, I'm using the same concept of understanding what are the criteria to be fulfilled to call it ventricular tachycardia and what are the criteria to look for ventricular fibrillation. The criteria are there. This is. Why is the slide not moving? Now it is come, huh? Oh, sorry. There's a lag. Okay. What is this? What? I told you, no? In the examination, if you mutter, you have failed. Speak like Dr. Tendolkar, loudly. He doesn't even might need a mic. I probably need the mic too. I just wanted to hear this. It's a French word, so point is not point, pronounced as point is point. Okay. So it's the end of the slide. I want to, if there's any questions you can ask, but I would just add one more. This is just a system. But as cardiothoracic surgeons, you have to definitely know what the ECG looks in these few conditions because you're going to be dealing with this condition. So go ahead and read and find out what the ECG looks for these conditions. So, end of the talk. If there are any questions about the system, I can answer. I won't give you any answers for exceptions to the rule, like organic chemistry. Okay, nothing. So a couple of people at least give a feedback. Not you. Not you. Not you. Somebody from this side. Oh yeah, please, absolutely.
You rightly approach the ECG from chamber enlargement. See, finally, you are going to face ECG as a case, long case, short case. Nobody is going to give you only ECG. So, sir rightly started with chamber enlargement. So, RA, what will you see? LA, what will you see? So, One way is reading ECG is P, PR, Q, QR, like that. Another is chamber enlargement. So your approach should be more for chamber enlargement. And so every disease, you must know what chamber enlarges, what chamber doesn't enlarge, never. Like ASD, LA left atrial enlargement is just not possible. Tetralogy of Fallot, RV, equal. So that approach which sir initial 10 slides or so, where chamber enlargement, that what all you should know very, very well. And then by permutation combination, you can say what disease is this. So remember, read ECG from chamber enlargement point of view.
Can you identify a couple of them to give feedback to? Call out their names and they will point out to somebody. So otherwise, nobody is going to stand. Just point out, no?
Any feedback?
No, not him. I told him not him. Siddharth is ostracized on that side. You are one, pick a second one.
Sir,
Arey, Siddharth, you
presentation
pick
had
up
lots
there, you
of-
pick up somebody. Why are you shy to pick up somebody? You pick up, no, not you also. I told him not him. These are all smart asses, smart guys. So I don't want them to answer because they're going to rob all the people from making mistakes and learning. Pick up another one, yeah. Just randomly pick up Ina, Mina, Mina mode. Who? Okay. Can you give a feedback? Okay. I just want you to understand one thing. The feedback correctly done is a huge learning exercise. So let's do this feedback in my way. Okay. The feedback consists of three steps. The first step is to give a unique compliment to me. Second step is to tell what all you learned that you did not know before. Third is, what did I miss out or what did I say wrong?
Thank you, sir, for a very.
It's not unique.
It's
You could say thank you to Tendolkar sir also and all these people for giving you an opportunity to speak. So
yes,
thank you is not unique to me.
so really good
The
presentation.
really thankful
No.
makes it unique.
I mean,
Why it's important is next thing you're going to say is what went wrong with me, no? But if you start with a unique compliment, it sets me at ease. And I will not defend myself when you're saying something wrong about me. And it also makes me feel happy. Okay, come to second one. What all did you learn that you did not know before?
sir, the chamber-wise enlargement, because we were dealing
Yeah,
with
well, that's another rule of giving feedback. Don't explain, just list the things that you have learned.
yes, sir, the chamber-wise enlargement, and also the arrhythmias part was.
What about the arrangement that you learned that you did not know before?
So, no, I mean, we have seen all the arrhythmias, but how to approach the arrhythmias, that is all.
What else?
And so,
She's struggling. Why? Because we all think when you have to, what did we learn? We are supposed to learn only one thing, and once you say one thing, my job is done. But if she says all the things she learned, and if you say all the things you learned, she also might remember that this also I did not know because you said it, she has learned now fourth, fifth, and sixth thing. So feedback is very important. Lastly, you have to criticize. You have to. You have to. That will show whether you're paying attention to what I'm saying or not. What did I miss out? What you did not understand? These are all part of the third component. Because if you don't understand something, it is not something wrong with you, it is something wrong with me. I have not been able to explain to you whatever you did not get. It is my fault. So you understand the importance of this feedback mechanism using these three components? Great.
Sir, the time request you to. Yeah.
Sorry?
Yeah. Done.
Thank you, sir. I request Dr. Muralidhar Kanchi, Professor of Anaesthesia, Chief Intensivist at NH Bangalore, to improve our understanding on echocardiography.
Thank you very much. Can you hear me? Thank you very much for the opportunity. I think we are not yet set. The ultrasound is becoming ubiquitous in medical practice. You go to any department, ultrasound is being used. Emergency departments, critical care, cardiology, of course, you have echocardiography. And most of the areas in the medical science use echocardiography. I mean ultrasound. In fact, it has become, one minute. It has become the fifth dimension of clinical examination of patients. After inspection, palpation, percussion, and auscultation, ultrasound examination is becoming the fifth dimension of clinical examination. In the next 20 to 30 minutes, what I will do is to give you an overview of the use of echocardiography in the operating rooms. So I will skip most of the theoretical bits because I want to show you some images so that we can have some discussion. And I want it to be a bit interactive. The 20 standard views have been described as early as 1999, and additional views have been added in 2013. These are the 28 views, and the indications for the use of transesophageal echocardiography. There are 4 categories. Basically, we are interested in the intraoperative use of echocardiography for refining diagnosis, for finding new pathologies which could have been missed in the preoperative examination, and also to fine-tune the surgical and anesthetic approach, and lastly to look at the quality of repair if it is reparative processes involved. And we should remember that it is contraindicated in patients who have esophageal pathologies. So if you ask me what to do when there is esophageal pathologies and echocardiography is important in that for that particular procedures, the alternative routes are doing the epicardial echo or epiaortic echocardiography can be done using the usual transthoracic echocardiography probe, covering it with sterile cover and putting on surgical field and getting the images. The passage of the echocardiography probe, especially the transesophageal echocardiography probe, is relatively easy in intubated patients. Only thing is you will have to use lubrication, and this mouth guard or bite guard, whatever you may call it, is absolutely important even if the patient is paralyzed, because the sharp teeth may damage the probe. And if there is any resistance to the passage of the probe, you must use a laryngoscope and pass it. We should not pass it across a resistance. These are some of the movements which are done: advance when you're pushing it in, withdraw when you're pulling it out, and there are anti-flexion when you're bending the probe forwards, retroflexion, flexion to the right, flexion to the left, and the rotation of the probe. This is most important. The probe is stationary there, but by using the multi-plane angles, you can change the direction of the ultrasound beam from anywhere from 0 to 180 degrees just by the press of a button. Before we actually see the pictures, I would like to identify these objects. What is this? These two are interrelated. This is Mercedes-Benz. So we will be describing some of the structures which we see on echocardiography based on the common objects which are shown here. This is a seagull. This is a seagull, and this is smoke. And this is fish mouth. And this is a trouser, and the pulmonary artery, when it divides, it looks like an inverted trouser. The trouser is inverted. So that's how these terminologies are used to describe the structures for common understanding. First view I want to show you is the mid-esophageal 4-chamber view. This is the mid-esophageal 4-chamber view. And can we identify these chambers? This one, you will be timing it, no? Please time. What is this chamber? Left atrium. This is left ventricle, right ventricle, and the right atrium. And this will be the interventricular septum, the mitral valve. Can you identify this bit of the mitral valve? Using the Carpentier-Edwards terminology, this is A2 segment and P2 segment. And here, the tricuspid valve, this will be the septal leaflet. Very good. This septal leaflet, and this leaflet can be anterior or posterior depending upon where the probe is there. If it is slightly higher up in the 4-chamber view, it will be the anterior leaflet. If it is lower down than this, it will be posterior leaflet. So when you see the posterior leaflet, you will usually see the opening of the coronary sinus into the right atrium. This will be the interatrial septum, and sometimes you can see interatrial septal defects in this view if you turn the probe slightly to the right to be able to see the entirety of the interatrial septum. Now we'll go to some same 4-chamber view in the mid-esophageal window, some pathological conditions. We'll try to see how to decipher it. So this is a mid-esophageal 4-chamber view. As we said, this is the left atrium. Is that right? This is the left atrium. And what is not correct in this? I mean, what is abnormal in this left atrium? Exactly. Spontaneous echo contrast is there because of the rollo formation of the RBCs, because of the stasis of the blood in the left atrium. There is impairment to the left ventricular filling because the mitral valve is not opening. It's hardly opening. This will be the A2 segment, you said rightly, and there's the posterior mitral leaflet, totally immobile. So what are the features in rheumatic heart disease? When you talk about mitral stenosis, we have restricted mobility, then we have calcification, then we have subvalvular fusion. And these are the features, and we cannot see the subvalvular apparatus here because of the fact that the echo beam is not perpendicular to the structure. If you want a good image, the echo beam has to be perpendicular to the structure. But if you are doing Doppler calculations, the echo beam has to be parallel to the blood flow. This is a paradox in echocardiography. When you want to see a structure using 2D imaging, the echo beam has to be perpendicular, that is at 90 degrees. Whereas if you want to see the Doppler velocities, the blood flow has to be parallel to the echo beam. So this has to be kept in mind. So what we are seeing is that the immobility of the posterior mitral leaflet, the antemitral leaflet is moving, but it's not normal. It is, you usually say J-stick deformity. There is a rollo formation here leading to smoke. And most important, other important thing is that the right ventricle is normally 2/3 the size of the left ventricle. In a normal situation, the right ventricle in this window, I'm talking about this window, in this 4-chamber window, the right ventricle has to be 2/3 the size of the left ventricle. But here you can see that it is more than the size of the left ventricle, which means that the right ventricle is dilated. It means that the right ventricle is dilated, and you can also probably make out that the tricuspid annular systolic excursion, which is called a STAPS-A, is reduced. You can calculate by putting the M mode onto this annulus. This is, what structure is this? Right atrium. You can see that the septum is bowing to the left. You can see the septum bowing to the left, which means that the right atrial pressure is increased in this case, which means that the mitral stenosis has progressed to such an extent to produce pulmonary hypertension, right ventricular enlargement, and right atrial enlargement, increased right atrial pressure, and probably this patient would be having hepatomegaly and maybe ascites and maybe pleural effusion. If you go to the other picture here, what do you see here? This is the left atrium, left ventricle, the mitral valve, tricuspid, right ventricle, and the right atrium. Here you're seeing some mass. What could it be? Sorry? It could be a myxoma. Myxoma is typically arising from the interior. There is usually stalk which is attached to it is attached to the intrathecal septum. This could be either a clot or it could be a myxoma. The problem with echocardiography, it will not give us it can only give a suggestive diagnosis. The ultimate diagnosis in such cases depends upon the histopathological examination. Now we'll go to the when you are doing the mitral valve assessment using three-dimensional echocardiography, you have to keep the aorta in the aortic valve in the 12 o'clock position. So that will give us the surgeon's view. Surgeon, when he looks at the mitral valve, when the left atrium is open, the anterior leaflet is towards the upper side and the posterior mitral leaflet is on the bottom side. And aortic valve should be at the 12 o'clock position. So you have the A2 segment and P2 segment in the same line as the aortic valve, that is the 12 o'clock position. And we have the two commissures, the anterolateral and posteromedial commissures on either sides. And we have the left atrial appendage. And you may also see a tricuspid valve here. By using two-dimensional echocardiography, if you do all the views, you will be able to see all parts of mitral valve. For example, if you are looking at the four-chamber view, which is depicted here, you can see the A2 segment, P2 segment. And if you are going to the mid-commissural view, that is mitral commissural view, you will see the P3, A2, and P1 segments. And if you go to the two-chamber view, you will see the P3, A3, A2, A1 segments. And if you look at the long axis view, again, what you saw here will see the same thing, but now P2 will be on the left side and A2 will be on the right side. This again, this one, the 3D imaging, you have the aortic valve here, the mitral valve. And how do you assess if the patient is going to develop this systolic anti-motion of the antemitral leaflet? After mitral valve repair, you have to look at some of the measurements which is mentioned here. You have what is called as the C-sep distance, that is distance between the coaptation point of the mitral leaflet and the interventricular septum. If this distance is less than 2.5 centimeters, this patient is likely to develop systolic anti-motion of the mitral leaflet during just after the mitral valve repair procedure. Then again, next is I'm showing you a picture of the transilluminated picture of the mitral valve. This by using special technologies, you can see that the mitral valve can be seen in this way. In this, what do you think is this lesion here? Yeah. That is positive. The mitral clip has been put here, so you're seeing two orifices. The mitral patient who had severe MR, where patient was not fit for surgery, you can do this device mitral clip implantation to reduce the degree of MR. Most of the patients have symptomatic improvement with this. Way patients with NVHA class 4 become NVHA class 1 or 2 because the amount of mitral regurgitation is reduced. Now I'm going to go to the next view in the mid-esophageal window. The multiplane angle is now increased to about 40 to 60. See, this is the angle which is increased to 40 to 60. You get the left atrium, left ventricle, and the mitral portions of the mitral valve here, P3, A2, and P1 segments. And this is described as the seagull sign when you describe it. Let us see this view. What is this view? Anybody can say? This is a two-chamber view. This is a typical two-chamber view, which we get at a degree of 90 degrees. the left atrium and the left ventricle. You have the P3 here, and whole of it, the anterior leaflet is in A3, A2, A1. And what wall of the left ventricle will be this? Any idea? This will be the anterior wall. This will be the anterior wall, and this will be the inferior wall. Please note that in the recent terminology, there is no posterior wall in the left ventricle as per the AAC, that is the American Society of Echocardiography recommendations. So this view is important not only to look at the mitral valve and the left ventricular walls, that is the anterior and inferior, but also if you just withdraw the probe a little bit, you will see the left atrial appendage here. And if there are any clots, you should be able to visualize them. And you can use the, what is the technique called as biplane. You can do a sort of cross section from this end to the other end of the left atrial appendage and look at each part to see if there's any clot there. And by looking at one window using biplane, you will be able to say whether there are any LA clots or not. Usually seen in patients who have mitral stenosis, especially if there is atrial fibrillation. And just above that, you have the Commodine ridge, and beyond that, you will be able to see the left upper lobe pulmonary veins. Left upper lobe pulmonary veins, which is again important to quantify the degree of mitral regurgitation, and it becomes important, especially in patients who undergo heart transplantations, to look at the flow from the pulmonary veins into the LA after you have done the anastomosis, just to see that there's no flow turbulence and there's no obstruction there. We'll go to the next view now. Please identify what is being shown. Now we are going to increase the angle to about 120 from 90. So this will be left atrium. Do you agree? This will be left atrium. This will be left ventricle, and this will be the interventricular septum. This will be interventricular. This is the right ventricle, and this is the aortic valve, long axis, and a bit of the proximal ascending aorta. A bit of the proximal ascending aorta is seen, and this view is important to put color Doppler across the mitral valve and across the aortic valve to look at any regurgitation. Important point here to remember is in patients who are undergoing CABG, if there is more than mild aortic regurgitation, please remember that these patients may not be suitable for intra-aortic balloon pump, because we know that if the aortic regurgitation is there, and if you insert intra-aortic balloon pump, it is going to become worse, and the patient's left ventricle is going to dilate, and patient may suffer bradycardia and cardiac arrest. It has happened once, that's why I'm telling you this. Then you have the A2 segment of the mitral valve and the P2 segment of the mitral valve here. And let us see what is this pathology in the next slide. What do you see here? Easy to make out. This is the LV long axis, left atrium, left ventricle, interventricular septum, aorta, the right ventricle. What is this? What is this? Easy. This is left atrial myxoma. 99% it is left atrial myxoma. Now we'll go to the next view. Please tell me what is the view and what is the structure seen. This is called as aortic valve short axis view. You are cutting the aortic valve in the short axis. Okay. So what are we saying here? This is the left atrium. You agree with that? Left atrium. This is the interatrial septum. This will be right atrium. This will be right atrium. This will be tricuspid valve. This is the right ventricular body, right ventricular outflow tract. And if you are lucky, you can see the pulmonary valve. As you are seeing here, pulmonary valve, and then the pulmonary artery arising from that portion. So here, if you look at this, you can see that the aortic valve is tricuspid. There are 3 leaflets in this picture. Sometimes it may be 2 leaflets, sometimes there may be 4 or sometimes 1. And this will be the left coronary cusp. The one which is shown here will be the left coronary cusp, and you can see the left main coronary stem arising from this cusp, this ostium, And this will be the right coronary cusp, because easy to remember, the right ventricle is here. Whatever is in relation to the right ventricle is the right coronary cusp. And the cusp which is in relation to the interatrial septum will be the non-coronary cusp. So here this image is important not only to look at the morphology. Morphology means how many leaflets are there, is the mobility good, or is there any calcium there? And you can put color Doppler and see if there's any regurgitation. And if you freeze the image and go to the mid-systole, the ECG will tell you the cycle of the cardiac cycle, which point of the cardiac cycle is there. If you freeze it and scroll it to the mid-systole, you can trace out the aortic valve area. By using the trace function on the echo machine, you will be able to know the aortic valve area. So the normal aortic valve area is how much? What is the normal aortic valve area? Yes, sir. What is the normal aortic? Easy to remember, 3 to 4 square centimeters. Aortic valve is 3 to 4 square centimeters. Mitral valve is 4 to 6 centimeters. Tricuspid is 7 to 9 square centimeters. So tricuspid is the largest valve. So if you measure the aortic valve area, you will come to know whether the aortic valve area is normal or it is decreased. So now we'll go to the next picture. I don't know what that is. So this is the same view. What is this? This we said is the tricuspid valve, and we have put a color Doppler here. It is showing severe tricuspid regurgitation. How do you quantify a tricuspid regurgitation? That's a big chunk of discussion. In general, by eyeballing itself, we can say that the tricuspid regurgitation is severe, taking care of the fact that the Nyquist limit, what is shown on the color Doppler here, is between 50 to 60. This scale should be minus 50 on either side, or minus 60. So the range is between 50 to 60. If I alter the scale, I can make it bigger or smaller. So please note this point. Whenever you are looking at the color Doppler, the scale should be appropriate. This scale facility has been given. For example, I want to look at the low velocity flows across the ASD or coronary flow. Then I have to reduce the Nyquist limit to be able to see the flow which is of a relatively lower velocity. So that facility is given for that purpose, but not to mislead the diagnosis. In most of the situations, we have to use a Nyquist limit between 50 to 60 on either side. Please let me know when my time is up. How much? 10 minutes, sorry. Very good. So this is the aortic valve long axis view, which is also, I think the probe has been pulled up a little bit. So this will become the ascending aortic long axis view, which is used to measure all the measurements of the aorta, which will be the aortic annulus, sinuses, sinotubular junction, and the ascending aorta. By freezing the image, you can make all the measurements by using the caliper function on the echocardiography machine. The aortic annulus and the LVOT diameter, this is the LVOT diameter are measured during mid-systole, whereas all the other measurements like the sinuses, sinotubular junction, ascending aorta, the measurements are done during diastole, because that is the time when it is bigger. Now let us see what is this picture. So these structures here, it's clear as is depicted in the schematic diagram on the left side. So what is this showing? This is a mid-esophageal aortic valve long axis view. What is it showing? A severe ER. See, it's a severe ER because of the fact that the right coronary cusp is not fully opening, there is restricted mobility, whereas this one can be left or non-coronary cusp, and there is the regurgitation which is reaching beyond the anterior mitral leaflet, which means that is severe aortic regurgitation. So in these patients, when you put the pulse wave Doppler in the ascending aorta arch of aorta or the descending thoracic aorta, depending upon the severity of the aortic regurgitation, you can see diastolic reversal of the flow. If it is occurring in the descending thoracic aorta, the systolic blood flow is gone, but it's coming back, diastolic reversal, which means that aortic regurgitation is very severe. If it is occurring only up to the level of aortic arch, it means that it is moderate. If it's occurring in the ascending, proximal ascending aorta alone, it means that AR is mild. So this is an important, and again, another case where you are seeing the aortic regurgitation in a similar aortic valve long axis view in the mid-esophageal window, another case, and some various measurements which are recommended when, especially when you're talking about aortic valve repair, you must do all the measurements, effective height and the geometric height, this is the coaptation height, the annulus, etc. have to be measured to be able to decide whether that particular aortic valve is repairable or not. Next view is the mid-esophageal bicaval view. This is bicaval view. This is the left atrium. This is the right atrium, and this will be the superior vena cava. This will be superior vena cava, and this is the inferior vena cava. You are seeing the interatrial septum here. And this view is very important, especially when you are doing ECMO cannulations, when the cannula is going into the IVC, into the right atrium. The echocardiography is useful to tell us whether the guide wire is actually in the intracardiac chambers, and also for SVC cannulations. And before that, you need to know about the interatrial septum. ASDs can be made out. Here, when you're looking at the ASD, especially if you're looking at PFOs, you have to reduce the Nyquist limit on the color gain, what I mentioned last time, so that the low velocities can be looked at. And this is a normal variant. This should not be mistaken for a tumor or thrombus. This is the crista supraventricular crista terminalis, and this is a normal variant. Now we'll go to the next image. Please let me know what this could be. This is called ascending aortic short axis. This is called ascending aortic short axis at 0 degrees. The multiplane angle is around 0 degrees. You see the ascending aorta in the cross section, and just next to that is the main pulmonary artery dividing into the right pulmonary artery and the left pulmonary artery. Usually the left pulmonary artery not visualized because of the bronchus there. There is a bronchus between the pulmonary artery and the esophageal probe. So you will not be able to see the left pulmonary artery. This view is important not only to look at the aortic diameter, but also to see any atheromatous lesions, especially if it is calcified or protruding into the lumen, which will dictate whether you're going to apply the partial or total cross clamp onto the aorta in patients who are undergoing off-pump CABG or coronary artery bypass surgery, or for any matter when you're going to cross clamp the aorta to deliver the cardioplegic solution. So this view is very, very important for that purpose. And just next to that, in most of the cases, you will see the superior vena cava here, as is depicted here. It's not seen in this picture, but superior vena cava is here. And this floating structure here is the pulmonary artery catheter. And in some patients who have pulmonary embolism, sometimes you can see clots in the main pulmonary artery or the right pulmonary artery. Left pulmonary artery is not usually visualized in this view in most of the cases. Let me see what is this view. Next one. We have gone into the stomach. This is the transgastric long axis view. The angle is increased to about 120. You are seeing the aorta at the bottom part of the screen. This is useful to determine the Doppler, spectral Doppler profile of blood flow across the ascending aorta. In patients who have aortic stenosis or LVOT obstruction, to determine the gradient across that obstruction or aortic stenosis, we can interrogate putting the Doppler beam across the aortic valve and determine the mean gradient across the aortic valve. So this is the LV, and because here the echo beam is going perpendicular to the papillary muscle and caudate tendinae, you can clearly visualize the papillary muscles and caudate tendinae. And when you report about the subvalvular apparatus, this view, that is the transgastric transgastric tooth chamber view is used. This is the transgastric mid-papillary view. This is the transgastric mid-papillary view. Here, when it is 0 degrees, when it comes to 0 degrees, I'm waiting for it to happen. 0 degrees, the left ventricle is almost cut in the cross section in the middle. You have the anterolateral papillary muscle here and posteromedial papillary muscle here, and you have the anterior wall here, anterior wall and inferior wall, and the inferolateral, anterolateral, anteroseptal, infroseptal walls of the left ventricle are visualized here. This is one of the most important views, especially in the intensive care center, not only to look at the volume status, but also to look at the regional wall motion abnormalities. You can pinpoint tell which artery is the culprit artery. If there is any regional wall motion abnormality, you can say whether it is the right coronary artery or the left circumflex or the left anterior descending artery. And you can see what happens to these territories after the graft is placed, whether the contractility has improved or not. But one thing we should remember, that if the myocardium is stunned, even if the blood supply is good, it may not reflect in improvement contractility. Then and there it will take some time to appear. This point has to be kept in mind. Next view, this is the papillary muscles which are seen, papillary muscle and caudate tendinae. This is the anterior leaflet, this is the posterior leaflet, this is the and the last view I want to show is the deep transgastric long axis. This is the deep transgastric long axis. So what you are seeing, this film, what chamber could this be? What chamber could this be? Left atrium, very good. This left atrium and the mitral valve, left ventricle, LVOT, and this is the aortic valve and the aorta here. On the other side, you have the tricuspid valve and the right ventricle. This view is also extremely important to do the Doppler interrogation across the aortic valve. If you put the Doppler and put the continuous wave button that on the machine, CW, you will get the spectral profile, and from that you can get the mean gradient across the aortic valve. And this is the only view where you can see the left atrium in its entirety using transesophageal echocardiography using 2D technology. In 3D, of course, you can get it by cropping the images, but in 2D technology, you can get the entire LA volume determined by freezing the frame and tracing out the borders of the LA and pressing on the trace function of the on the machine. So LA volume, if you want to determine, this is the view to see. This is the upper esophageal aortic arch short axis, where you can see the pulmonary artery on the left side of the image. Same thing is seen here. And this is a patient again with the double valve lesion. The mitral valve is not opening fully. Left atrium is enlarged. Left atrial pressure is high. That's why the septum is tilted towards the right. You can see that the mitral valve is not at all opening, hardly any opening. And then there are two valves involved in this case. There is aortic regurgitation as well. Aortic regurgitation plus mitral regurgitation, mitral stenosis. And then same thing is shown here. And if you notice here, the right coronary cusp is not moving. Same thing is shown on the short axis here. The right coronary cusp is not moving. This is the left coronary cusp and non-coronary cusp. They are opening, but not fully opening, but the right coronary is stuck and not opening at all. And you also can use echocardiography to look at the IVC. And here the IVC is grossly dilated with hardly any collapsibility or distensibility, which indicates patient is in gross right heart failure leading to plethora of the IVC. This is the 17 segment model described by the recommended by the American Society of Anesthesiologists to look at the regional wall motion abnormalities. The left ventricle is divided into three portions: the basal portion, the mid, and the apical portion. Each of them is divided. The basal and mid is divided into 6 segments each. The apical portion is divided into 4, and the apex itself is the 17 segments. So you have a total of 17 segments. The right ventricular function also can be analyzed using echocardiography, and there's the use of strain techniques to determine the amount of right ventricular contraction. To conclude, the T is a standard monitoring and diagnosing tool intraoperatively, not only to diagnose confirm the diagnosis, but also to refine the diagnosis and to see if there is any new finding, or if there any change from the point of TT being done on the outpatient and patient actually landing up in the theater, but also in all the valve lesions. And in fact, the American Society recommends use of TE for all open heart procedures, and it has become a standard practice. With that, I would like to announce that we have the workshop in August. Please join us. And also we have the critical care echocardiography fellowship under the with the support of the Indian Association of Cardiothoracic Surgeons. We are doing this fellowship. Please be a part of that. And thank you so much. If there are any questions, I'll be happy to take. Thank you so much. Thank you. Somebody wants to ask question? Any questions?
We'll have a short tea break. Tea break, sir. The tea is yet
Just
to
a
come.
tea break.
Yes. Tea is yet to come, so.
There are a lot of people sleeping.
Did I put people to sleep? Actually, I don't keep it very long. Invariably, whenever I give a speech, they will go to sleep. And once even the chairperson was sleeping, I asked him, sir, please get up. Why you're sleeping? He said, sir, your voice is so good, I cannot help but sleep. That's what he said.
So once one person said feedback that your lecture was excellent, and I could sleep. That was the feedback. Why the lecture was good? Because Prasanna has noted, Prasanna has noted his students sleeping.
Dear friends, we would like to welcome Dr. Sudhanshu Bhattacharya, the pioneer surgeon in the world in coronary bypass surgery. From Mumbai, he has come. He's a professor and head at Mumbai Hospital. Sir, please be seated, sir. We are privileged to have you, sir, amongst us. Sir is the teacher of Dr. Anil Tendolkar, the teacher of teachers. So we have 4 generations here. You are the 5th generation. It's really a great get together. Thank you, sir.
So we are discussing CPB complications. So aortic cannulation done. You have inserted the cannula. After that, what you do? Snug it. Snug. Next, what you do?
You tie.
You release the clamp.
Clamp.
You release the clamp, isn't it? No blood is coming.
It has hit the posterior wall, it probably
One possibility, the
Was-
tip is touching the,
posterior wall.
typically in which type of cannula?
You
Straight plastic
straight plastic.
tip cannula. Any other possibility?
So it has caused dissection.
Cause dissection. So the tip is lying in the
False lumen.
wall,
Wall, yes.
wall of the artery.
Artery.
Typically seen when, which conditions? Somebody
Some Marfan's
talk fully, no?
connective tissue disorders.
Thick wall.
Yes, sir.
Connective tissue disorders, which is the commonest condition which causes thick aortic wall,
So,
atherosclerosis,
wall. Yes, sir.
on pump CABG,
Yes, sir.
and your tip of the other end is, your tip of the cannula is very short. Okay? So the flow is not proper.
Yes, sir.
What is the dangerous part of this aspect of this?
Air
The,
entering.
the opening of the cannula is partly in the lumen and partly in the wall. That's the worst.
Yes.
Totally in the lumen, no problem. Totally in the wall, you can come to know. But if the partly in the wall and partly in the lumen, you cannot make out very easily. So remember,
If you have specifically EOPA cannula and it is not coming out properly, anything else you have to check whenever you use a long straight cannula?
It could arch vessels cannulate ho jayenge.
And then,
So it could-
okay, if it is in the arch vessel, what could be the problem then that? And how will
Selective perfusion of the
you, brain?
brain. Yes.
How will you recognize these things
Uh,
stepwise?
uh,
Something you can ask the anesthesiologist to do.
So he would check the
Carotid. Okay. Now let's assume that you went on bypass with this error for some reason. What are the ways you could detect that there is
selective perfusion.
selective perfusion to the brain?
Yeah.
Yes.
You are cardiac surgery student, no? What are you scared of?
No.
Which year?
5th years.
5th year. From which place?
Apollo Hospital, Chennai.
Apollo, Chennai.
Yes.
So sir wants to know one side perfusion. So how will you come to know about it?
Saturation.
You're on bypass. And
Saturation of what? There are so many saturations on bypass. Oxygenator, pre-oxygenator, post-oxygenator.
if you say saturation, what saturation?
Limb.
Huh?
If blood, all the 5 liters goes to one carotid artery, what will happen? What will the pressure in the, suppose the pressure is
Will be
in
low.
right radial.
Will
What
be
will,
low.
it will be
Low.
Everything is going into that innominate artery, no?
It will be high.
High, sir.
Why do all the blood flow goes into right innominate, but innominate? Why the selective cannulation is common of the innominate? Straight. It is in line with ascending aorta. That whiteboard is
Gone there.
ideally speaking, this is what God has done the engineering. Tomorrow when you are in Delhi, please see the flyovers. All the exits are in this arch. All the exits are at tangent to that spot.
So that you can get out
You
straight.
can get out straight. exits are not right angle. All exits of the flyover, suppose circular flyover, so it is like this. You can get out very easily. So innominate artery is in directly line with ascending aorta. This is God's creation to ensure that full pressure oxygenated blood goes to brain. So the pressure, if recorded in the right radial, will be too high. And suppose recorded elsewhere, 0.
You said some saturation. Can we do any saturation? Is there any device if it is attached? Since you use the word saturation. Have you heard of NIRS? So NIRS can be unequal, but then anything
NRS.
else?
NRS will be good.
On which side? On the left side it will be low, right side it will be high. But clinically, any other thing that you can ask the anesthetist to do, lifting parde mein rehne do, lift the parda and what can this be seen? What will happen to the face? One side will be congested, the other side. Then can you look at the pupils? What will happen to the pupils? One side perfuse, one side not perfuse. One side will be constricted, the opposite side will be dilated. There's no this thing. Okay, so flushing of the face, diaphoresis, all these things.
Dissection has supposed to have occurred. Suppose. What is the classic
Sign.
triad of dissection? She says she is first year. So I am omitting her.
Classic sign of dissection.
Classic sign of dissection. You will see some sign. Perfusist will report one sign. What thing perfusist reports immediately?
And
one high line pressure.
And
now this is dissection.
See, you said that if I put a cannula which is touching the wall, or if the arterial line is kinked, also there is high line pressure. No, there are multiple causes for a high line pressure. But then, what makes you say the moment I hear this, I immediately become
dissection?
Think of dissection. Falling return.
Falling return. So where will you look? You surgeon, heart.
Heart.
What will be the heart in dissection? Perfusion related resection. Heart will be full or empty? Heart will be
empty. Another thing that you must
so remember lifetime, empty heart, empty pump.
High line pressure. The important, another thing that subtle sign is if the purse strings, aortic purse strings which were dry has suddenly started bleeding, think dissection. Don't think, okay.
Which were dry before.
Dry before.
That is important. Tumhare purse string, they start bleeding right
at
from
the starting.
So
now, when does this rule get broken? High line pressure and low venous reservoir. And the perfusionist only says, I am not able to maintain the volume. Line pressure is not high, but a dissection is occurring. In which condition? And all of you are modern day, minimally invasive surgeons. I'm giving you the clue. Which peripheral cannulation?
Femoral.
Femoral.
So where does the blood go?
Where does the blood go in such a case?
Retroperitoneum.
No, femoral fracture can have 2, 3, 4 liters.
Retroperitoneum. And the bad part is the resistance of the retroperitoneum is very low.
So line pressure.
So perfusionist is unlikely to tell you about line pressure resistance. Retroperitoneal bleed can accommodate 3-4 liters. And you will not see any distension or anything. So what is the golden rule for peripheral cannulation? Sorry? One is under vision. Anything else?
Need not be under
the
vision.
guide wire should be seen in the aortic lumen on trans-esophageal echo. Is the rule.
Yes. Another thing that how you have to see, especially in mix, is that when you not only is the guide wire seen, the flow in the aorta should be maintained. Okay, that is why you should see originally the ejection coming from the heart, and as it comes, this should.
Okay, aortic cannula connected to artery. There is an air bubble. What will you do? Now, one after one. You want to answer? Because you told me you are first year.
He is not in first year now.
So who want to answer? Pratik, air bubble.
After it is entered into the
Ding dong. You have connected air bubble. Tell me the steps.
We'll disconnect again.
And then
then-
blood
How
on
do you
your face.
disconnect? Just for my knowledge.
Oh.
How do you disconnect?
I'll tell them to switch the
How do you
pump.
disconnect like this?
No, sir. I'll tell them to switch the
How
pump.
do you disconnect?
I'll clamp the aortic cannula first.
Clamp the aortic cannula.
Yes. After clamping
And
the
what
aortic cannula, I'll take a blade. With the blade, I'll put an incision where
You
the
really
connection is there
Slit it open.
and slit it open.
Slit it open.
Slit
Perfect.
open.
So
Yes.
many of us don't pass it fully
Yes, sir.
on the ratchets. Just once, just make sure, and then
Yeah.
air bubble. You put it again there is air.
Same.
Same procedure to be. One student, by the way, told me I will pass a 26 number needle and remove that air bubble.
Is there any other way you are having a EOPA cannula? Any other way of removing the air?
Side port.
Side
How do you remove the side port and how do you? No, you clamp this side and don't totally remove the.
Yes.
Just
Tight.
loosen it.
And that time you tell the perfusist
Perfused
to start giving.
the thing.
And when that is on, you tighten.
Tighten it.
And immediately tell the perfusist you have tightened.
Tighten.
Okay? Before disconnect, how do you disconnect the air, the arterial line? Pratik, you only answer.
So,
You hit or don't hit?
just
Not
you
Pratik
just
will answer.
place it vertically and tap the.
He's circulating, no?
Yes, sir. If it
He's circulating full.
to remove all the air bubbles from the filter,
The slow speed, they don't come out.
yeah, it will come out, sir.
Those which are stuck to the wall.
That will come out.
What
the
is the
speed.
way that in your hospital that they ensure that you can rapidly
The the lines.
What does the perfusionist do? Prime with
Prime.
what? Priming, you prime, huh? What is Del Nido got to do with this, ma? Huh? How can you ensure that, let us assume that that the pump is on standby. We know that there is a possibility of a crash and I need to prime the pump fast. What is done? It is done in many of the hospitals. Huh? Autologous alarm. It is not primed. It's an empty, dry pump. No, before I put the crystallite, I'm telling you, no, if you put crystallite, what can be, you can flush the circuit. It is done in your own hospital. It is done in your own hospital.
Anyway, you tell us.
It is carbon dioxide can be used to flush the system and lock. So you may not be knowing it, but all op cabs, if you are keeping a standby pump, the carbon dioxide is kept flushed and kept locked.
Why carbon dioxide? How many times? 25 times more soluble than.
And
They're coming
how
back.
long can you keep this pump like this?
Sir, coming back.
How long can it be kept? This sort of pump. Tomorrow you're going to Jumratalaya Medical College and you're going to start your this thing. Pump is put. Sir, we have to use it, sir. Let's use it tomorrow. But no case. You throw the pump away or what do you do? The oxygenator. How long can you keep it?
24 hours.
No, you can keep it for 1 month.
People have kept it 7 days and they have done proper studies. Study ended at 7th day.
But
So
now,
it can be kept
it
for
has
a,
been done now till
but
1
should
month.
be closed circuit.
It should be closed pump.
Most
Closed
important closed
oxygenator.
circuit.
1 month they have proven that it can be
Not
kept.
disconnected. Okay. Pratik is telling us de-airing. So you start tapping.
Yes, sir.
Which part you tap?
The arterial.
Why not venous?
Because we want arterial line to be.
Venous line air, not to bother.
That will we anyway apply a vacuum to the to the venous side. So the
venous side air.
It will filter out. The filter. Yes.
What are you at? Plus, there is a reservoir level.
Yes.
So which will take care of the air. Okay. Tap. No air. Next step.
Then
Only Pratik will answer.
after that, we'll clamp the aortic line. First, we'll tell them to switch the pump off. Pump should be off. Then we'll clamp the aortic line and divide the line and keep it ready for the cannula.
I'll ask you now a question. You clamped?
Occlusion. What is occlusion? Like
When-
occlusion?
When the pump is running and
Next.
What is
What is
occlusion?
occlusion? Pump occlusion. Pump
No.
occlusion.
Level of fall of the water column after
Level of the fall of the water column after you have stopped. There are various levels.
Please speak on the mic because online people are
Various
unable to hear.
falls, various falls are accepted. Least accepted, highest occlusion is no fall over a period of 10 minutes. What is the importance of occlusion? You drive car,
Yes, sir.
in the car 2 meters. One is speedometer and another is revolutions.
Revolution.
Correct?
Yes, sir.
And normally RPM and speedometer should be parallel to
Yes, sir.
each other. So on the same line, what will happen? If your pump is rotating without occlusion, what will happen? What will happen? No forward flow. Pump calculates flow from the revolutions. So if it is told that the tube is 3.8, it calculates volume of 3.8 multiplied by revolutions, and you get a calculated value of the flow. So you will feel you are giving adequate flow, but actually flow will be much less. That is the importance of checking the occlusion. Each center has got different level of occlusion setting depending upon the pump, depending upon the quality of the tube. So remember this, pump occlusion.
What is the setting put generally? What is the term used for the occlusion setting of the arterial line? What is the technical term used? It's given something, a negative name. Just non-occlusive. Whatever is the just non-occlusive can be one inch in a minute or 1 centimeter in a minute. That is defined.
Most of the centers accept 1 inch
per
in a
minute.
minute. Okay. So which is the pump which is never set at just non-occlusive in the heart-lung machine? This has been made as a mistake and it has given problems.
So,
which is the pump head which is never set at just non-occlusive? Cardioplegia is not set at just non-occlusive. Because we are giving what? 1 liter and you set it back, the washback will occur.
So coming back to Pratik again, pump is non-occlusive. On bypass, how you will come to know? You, perfusionist, anesthetist, all. What will be the reservoir? Remember, anytime bypass is to be discussed in terms of reservoir, oxygen, flow, pressure. So what will be the reservoir? उधर के उधर ही डांस कर रहा है ना, आगे नहीं जा रहा है, लेकिन flow is coming. So reservoir will be
constant volume.
Over full.
Okay.
Pressure will be
low.
So low pressure with high volume. Our dissection was what? Low pressure with low volume.
Now, if the perfusionist is not very bright and it continues on for some time, what other thing that you will see if you have a non-occlusive pump? Suddenly the anesthetist says that something is wrong, and then suddenly one is hematuria can occur, number one. Number two, the flow is inadequate. So what will happen? Hyperlactatemia will occur. Mixed venous, if you're measuring, will be high. Okay, signs of underperfusion will be there. Acidosis.
Okay. Constant air is coming in the venous line. What will you do?
Both.
Check this.
No,
he said hematuria also occurs with over-occlusion.
Yeah.
Both
Over-occlusion is
and
the
under-occlusion.
Over-occlusion is a major cause.
Yes.
It's almost like a grinding.
There it will grind, here it will slosh. RBCs are getting damaged with both. Okay, then?
Coming back, air in the venous line.
We will check the snuggers. Snuggers, I mean...
Take the snuggers.
Yeah.
Very good.
Then
commonly where from it comes? Purse string. If you have taken a too large a purse string, the purse stringing effect is not adequate. Or in that purse string, you have taken a too large an incision
And
for
it has
that
extended out.
cannula size that is coming. What will you do? Small air Perfin is saying, I can manage. Perfin is always trying to be good books with you. तो तुम निकाल देगा. बहुत कट करता है out. बराबर ना? They are so happy. I have read their mind. Additional posting. Danger, MTRA. So you may create even more problem. Third is, but don't forget, holes of the purse string. The RA is paper thin and you are using thioprolene.
Today with vacuum assist, is it in the era when we were not using vacuum assist, what would be the problem? And today we don't run to, it doesn't become disastrous. What was the problem if you are not in centers which are not using vacuum assist? An airlock can occur.
Yes, sir.
How is the airlock removed?
That is my next question. Pahla, air coming. If you have not taken a snugger around the cannula,
Yes, sir.
take a snugger around the cannula and snug it. For example, for mitral valve replacement, I do bicaval cannulation, but I don't snug SVC and IVC.
Yes,
So simplest thing is to do what? Snug SVC and IV. But remember, while snugging, you may tear the KVA posteriorly. So you have to be not to
If
be
you
in a hurry.
if you snare SVC and IVC, what type of bypass is it? Total cardiopulmonary.
Total cardiopulmonary. True total cardiopulmonary bypass. Another trick, small trick I do, I take a wet gauze and put it around that snugger side. So that acts like a
Water seal.
water seal. Okay?
Then
Okay, you are doing mitral valve replacement, bicaval cannulation. You are doing, how many MVRs you have done?
One, sir.
One, fantastic.
Yes, sir.
Correct person to do it. You stab it and the perfumist says airlock.
airlock. You're going through the LA.
Perfect.
Okay, sir.
You're going through
You are going through
the
LA.
LA.
The
Sir?
PFO is
PFO.
No PTMC. No PTMC. That is one cause, but
Another cause
most common cause, no
is-
PTMC.
is what?
You know PTMC?
Yes, sir.
balloon
mitral.
Not done.
Yes, sir.
That is another cause.
No PFO.
By the way, how you will come to know previous PTMC has been done?
So,
Cardiology will always overlook the hole. How you will come to know on bypass? On full bypass, what will happen? Through that hole?
sir, RA will be collapse, sir.
RA will collapse.
Array, LA also will collapse through that hole. LA nice,
Bulging, no?
Yes, sir.
similar to this.
It,
फंस सकता है.
so it will decompress the LA.
Stab and perfume space lock. जल्दी बोलिए. Lock हो गया.
You stabbed a patient with mitral stenosis. You're going to do an MVR, and you, when at what stage will you get how can you damage the interatrial septum? Airlock has occurred. You open the LA and grrr, the air starts coming.
Actually, open the RA. RA. Yes.
When you are trying to stab the
Waterson groove mein, sir, we have injured the RA.
That is the time. Or if you are not going, just stab it. What you thought LA is not LA, but is RA. Typically occurs in small LAs.
Yes.
Large LA,
you can see the
can do anything. What will you do?
Defect and then
With what? Shh, ठहरो ना. With what? 6-proline. On table hai kya? For MVR? Unless you routinely do it. Once somebody asked me to speak on complications of bypass. On phone he said, sir, you have got a vast experience. Vast experience. You can't call me. Temporarily, can you do something to close that hole? Correct. Cross clamp, side clamp. So I'll ask you which side batting clamp? Satinsky, Dera, Cooley. So all of you know, rather than talking generic terms, talk specific term. Or take a right angle mixture. Stop the air leak. Now you first attend to removal of the air lock. How do you remove the air?
Sir, yes. With saline, with the saline, we lift the, no, sir, we lift the,
You will
Air
raise-
is lighter
Raise-
than water.
yes,
You
sir.
will raise the venous
Line up,
in such a manner
yes, sir.
that
The
The
bubble.
air bubble goes towards the perfusion side.
how will you push that air? Ask the assistant to press
Press
the
the
Abdomen.
abdomen
Yes, sir.
or press the heart. RA will become full.
Yes, sir.
Arterial line is going on. Ask the perfusers to start giving.
Yes, sir.
Press the heart. Raise the venous line.
Yes, sir.
And
Race, it's called as racing the bubble down.
Okay.
please.
Mitral valve, you are doing an aortic valve, you have got a two-stage aortic valve. Air is coming.
Can you repeat?
What is happening?
Sir, can you repeat it for the online people?
AVR going
You are
on.
doing a calcific aortic valve excision. You have put a RA cannula, air is coming, airlock, perfusion. What is happening? That is a
Two-stage
two-stage can.
So. So there's pericannula,
One is
Pericannular
It is
air.
telling you very specifically. Calcific
Aortic valve is cutting. Excise the valve.
yes, acha.
He's giving. Tell it loudly.
Or else you have a redo AVR, you are excising the previous valve and perfusion says the air.
Sir, in the process of excision of the aortic valve, probably we've injured the torus aorticus portion and RA.
Which one to put air into aorta?
Non-coronary
Sinus.
sinus.
Okay. ESD AR.
Yeah.
So moment you open the aorta, air from aorta, aortic valve, LV, VSD, RV, tricuspid valve to RE.
While excising the aortic leaflet with the calcium, heavy calcium, or while excising the sewing ring, you might have accidentally entered into the, through the interventricular septum, into the right ventricle.
You're giving cardioplegia, heart not stopping. Cardioplegia, you said give cardioplegia, heart not stopping.
So
Apart from causes related to cardioplegia, we are constantly asking you surgeon related causes.
So we might have missed the AR.
You want him to give?
One thing
missed
is that
AR.
one
Missed
thing I would
AR.
like to tell is whenever you are doing this, think of it in ways which you can solve the problem. So classify it into aorta distended, aorta not distended, tense. Okay, if the aorta is distended and the heart is not stopping, aorta flaccid and heart is not stopping. Similarly, line pressure, cardioplegia, line pressure high, line pressure low. So you have four options: aorta empty, line pressure low; aorta empty, line pressure high; aorta distended, line pressure high; aorta distended, line pressure low. So
Can remember.
so four, it is 2 and 2. You are seeing aorta here.
Permutation
Four. Now, so which one? If aorta is distended, line pressure normal.
Forget of aorta empty.
Empty.
AR.
AR.
Okay. Aorta distended.
Aorta distended.
Think.
Line pressure.
No. Always make it a habit of tracing the whole circuit. So starts with pump. Just now we saw pump occlusion.
Cardioplegia,
not
line pressure high.
Cardioplegia clamp not removed.
No.
Then those who are reusing the cannula, the stylus has got a butt around that stylus that remains inside. Then third is the cardioplegia which you say has punctured the aorta, has not punctured the aorta. Then comes to root, the ostria. Like that you go on tracing. Coronary artery disease, osteal disease, etc.
For example, if the line pressure is normal, aorta is distended adequately, what is the possibility? He's saying my cardioplegia is going well and the aorta is distended, heart not stopping. the potassium could, then you have to start thinking of the potassium. This aorta distended, cardioplegia, but still not harder. He's saying swear, sir. We used to take potassium and this thing. Potassium is also adequate. Heart not stopping. Cross clamp not put properly. Okay, you have to think in that.
Heart has stopped, but heart comes back in
Next to no time.
2 minutes. You. Oh, this.
Inadequate dosing.
Sorry? How will you confirm? How will you confirm?
Mike.
We'll check on the PA side and the
PA side.
aorta PA groove. We'll check the clamp.
Can you just open one of the limb of the Y-shaped cardioplegia cannula? You are using Y-shaped cardioplegia cannula?
Yes, sir.
Can you open one limb?
There should be no
Yeah.
blood coming.
If the cross clamp is incomplete, what will happen?
No, if it is incomplete,
Incomplete
I have
cross
stopped
clamp.
cardioplegia. I have stopped cardioplegia. Clamp is in. If I release, what will happen if
Blood will
blood will come up? If the RA is open, what do you say? The blood fat
Coronary
coming
sinus,
from the coronary
sinus.
sinus.
Okay, so always remember any problem, trace the whole circuit. Make that as a habit.
One question that I'll ask.
How will you give? Nowadays, this is not a big problem of giving second cardioplegia. You are doing MVR, your second MVR. What cardioplegia you give?
Sir, St. Thomas.
You have to
Wow,
repeat.
exactly what I wanted you to say. So you repeat after how many minutes? 20 minutes he repeats. How will you repeat the second cardioplegia?
Half the previous dose.
What maneuvers you will do before giving
Several,
the second
sir,
cardioplegia?
when we are about to give the second cardioplegia, we would relax the mitral retractor and leave the heart in a relaxed state and ask the. I mean,
You are considered. Heart is relaxed.
retractor has to be removed.
Retractor.
Done. Released. Loosened.
Anything else? In 20 other mind.
There is air in the aorta.
Vent can be on.
You can open the side.
Even the aortic side sutures which you have taken have also to be loosened. Third is, what is the danger of second cardioplegia or third cardioplegia? Air in the
root.
Which coronary?
Right.
Left. Right.
Air is lighter than water.
50%, no? So keep on looking at his eyebrows. If you say left and he says like this, sir, tongue of slip, I meant right. Okay? So what will you do to prevent air going into the right? I pass a SIMS cannula from mitral valve into aorta. Open it up. Make aortic valve incompetent. And ask to give cardioplegia. And air is removed. Number 2, put a pinch or put a vascular mixture on the proposed RCA opening. So you start the cardioplegia and then you release all that.
How do you give blood? Aorta is opened and you have to give cardioplegia for a aortic valve. What are the maneuvers you do to give cardioplegia to the ostia? And how do you know it is going properly?
So we lift the anterior wall of the aortic stump, I mean the open aorta, and visualize the right coronary ostia. And
I
then
want to see, I can't see. I can't see the right coronary ostia.
Any maneuver is trying to do something. Correct. You means, we means who? Assistant. Evert.
Evert the lower lip of the aorta by?
Evert.
The surgeon holds the
margin.
And the assistant compresses and then everts the aorta. Now you put the costial cannula. How do you know that the cardioplegia is actually going?
sir, there's no extravasation of
okay, no leak.
no leak in the around the
ostial cardioplegia or root cardioplegia?
Ostial cardioplegia. He's giving to the RCA. We want to know how you are giving it.
What cannula you use?
So right angle, sir.
No, I'm asking him.
So right angle ostial cannula.
For which one?
metal,
The
metal
plastic tip, sir.
used since
Plastic tip,
ages,
sir.
You're using those soft.
soft plastic tip
Paper,
cannula.
okay.
Okay.
How do you know that? How do you angulate it for the left? How do you angulate it for the right?
So for the right, we lift it up towards. I mean, hook the RCA open.
Right, more angle. Left, almost
Almost flat,
straight.
sir. Yes, sir.
Okay. How do you know cardioplegia is going?
So the heart starts to cool.
So every time you'll keep a
There is
watch.
the
heart.
line pressure, cardioplegia line pressure is
Line
okay.
pressure is normal. Okay, number one. Number two.
And there is no leakage.
You said no
No,
leak.
I object. I'm asking you, how will you check? Don't tell what the perfectionist will answer. You must have your own.
Visualize the coronaries. You may see the coronaries. Then two.
What is the color of the coronary veins when you give ostial cardioplegia? Actually, any cardioplegia.
Any cardioplegia. In fact, we say
Pale
see that.
All of you must know this. Yes, madam. Coronary veins, what happens?
What happens to the coronary veins as
Loudly.
you give cardioplegia?
Loudly. First, the color is dark.
Then
when you start the cardioplegia, dark because of all acidotic blood is coming. Next, it becomes bright.
that means it
And
has
finally, the color matches the color of blood
arterial.
which you are giving through coronary ostial cannula. Remember this three.
it has met
And the
requirement.
veins should look full, should not look empty. Okay. Number two, blood should come from the opposite ostium. And that blood will be what color? Dark in color.
Third,
And heart stops should be the last answer.
anything else you will
Because
say?
even if you don't give cardioplegia, heart will also
What did
will
you say?
stop.
There will be misting. As long as the cardioplegia is flowing, there will be misting of the cardioplegia line.
We use a reusable metal cannula, and on our finger, we get what is called a refrigeration effect. Because of the cold cardioplegia constantly passing under our finger will become continuously cold. If the moment the cardioplegia stopped, we immediately realize that my fingers, I'm feeling warm now.
If you are using the plastic, there is that metal this thing, you will find the misting on that.
Okay. So that is,
Cardioplegia, heart not stopping while giving cardioplegia. We did that?
Yeah.
Oh, we did that. Then, okay, we'll just say that you're going to come off and there is no ejections. Mitral valve replacement, no ejections.
Prosthetic valve or
Prosthetic valve,
Can
MVR done.
give it to the.
Yeah,
We are
give him.
asking him too much.
MVR done. See, I will give you three situations. An MVR done, a VSD done, a ASD done, no ejections.
Eki situation.
First is MVR, no ejections. Stuck valve in what position? In a closed position.
Moment you are told no ejection, where next you as a surgeon will look.
Arterial tracer.
My dear, no ejection. You as a surgeon, just now I
No ejection.
Just now I
mitral
took the
valve
exam.
replacement occurring.
Just now I took the name of Dr. Bhattacharya. And what I told you, trust what? Trust what? Your eyes. Trust what? Your ears. Trust what? Your fingers.
What do you see there?
Don't bother about what they are saying.
That MPA will become tense.
So you look whether the
Elate.
heart is beating or not. Not beating, no ejection is different situation. Heart beating, but no ejection is a different situation. Heart beating on pump, but moment you go off pump, not beating is different situation. Heart not beating on pump, different. So everything is different. So first thing you must say, I will look at the heart. How is it? Excellent beating on pump. The moment you go on pump, heart is beating very well. Moment you go off,
no ejection.
Heart starts
distending.
So something to do with not valve, but suturing of the valve. Something to do with additional valves you have left alone. Heart not beating at all on pump also. That means by doing MVR, you have damaged the circumflex artery.
Or you have gone too deep in the AV nodal area.
So don't immediately jump to conclusions like this. First, you will ask whether the heart is beating well or not. Not beating well could be cardioplegia, air embolism. He has taken 200 minutes to do his second MVR. Very heavily calcified wall, clot in the LA, calcified wall, all the problems. So he has taken 200 minutes. So all those causes you have to think that the heart won't beat well on bypass. Heart beating well on bypass, moment you give load, heart is giving trouble, there is additional wall lesion which you have missed.
If you have a ASD, again, heart contracting very well after you release the cross clamp, but when you try to come off bypass, no ejections. TAPVC. Okay. VSD, you close the VSD. You may close the pulmonary valve, or else it could be
os infundibulum.
They think, or it could be a os infundibulum of a DCRV, which you have missed.
Which you thought as VSD.
VSD. You close the DCRV rather than.
So always think of mechanical. Beating well on bypass, off bypass not beating well. So you have created some mechanical related problem. Chalo, how do you go partial? You go on partial bypass. You go on partial. MVR going on or ASD going on? Partial bypass.
Sir, first we will go on aortic cannulation.
Eda tambi operation ayache. Now you are going off bypass.
Okay. Weaning off.
Which year you are?
Sir, final year.
Final year.
You are weaning the patient.
You are weaning the patient off bypass.
Okay, sir. So
your boss has walked out saying that now wean off and go off. So what are the steps of weaning off?
sir, we will first see how the heart contraction is.
Boss permission tandirke noke cholli vechirka po off bypass. Rate rhythm, QRS, PR, whatever sir said, all ECG, perfect. PR, QR, T wave, STD changes, nothing. Beautifully beating. Go off bypass. How do you go off bypass?
So we will ask them to what is the flow. We will ask them to reduce the
flow.
Reduce the flow.
How much?
Sir, if it is like 4 liter, then we will step down.
So you'll tell him to do what? 4.3 liter.
3.5.
3.5. So best thing is to tell what? Percentage rather than absolute value. Done. Next.
Then we will ask them to reduce the.
Do you go on single venous cannula from 2 venous cannulae?
Yes, sir.
Yes or no?
Yes, sir.
You are saying yes, sir, like this. So very safe answer. I meant no, I meant yes.
Which cannula do you commonly remove?
Sir, first.
Remove IVC.
IVC or SVC?
IVC, sir.
IVC cannula you remove.
Why? Flow.
How do you cannulate the SVC?
Sir, from SVC to RA we will keep.
From RA to SVC.
SVC to RA, sir. Cannulation we will. First we will.
That means basically you are cannulating from the RA appendage, is it?
Yes, sir. RA appendage. Yes, sir.
So you are going to pull out the cannula and keep it in the RA body.
Yes,
okay,
sir.
fine. Then that's okay. If
IVC cannula you are removing. You first put a clamp. Suppose some smart first year resident removes that clamp. What will happen? अभी उसको पूछा ना अभी तुम लोग ना कर
backseat driving.
Air will go into them.
So remember, on bypass, venous pressure is negative. This you have to keep in mind. Very commonly, students say blood will come out. Air will get
inside.
Okay?
Yes, sir.
Inside where?
Inside the cannula, sir. Pump.
Correct. Into the pump. Reservoir.
Reservoir.
Okay?
Venous line.
So what is the advantage of removing IVC per string first?
You wanted to remove IVC, no? Why did you choose to remove IVC?
Why not this?
Sir, on pump.
How
if
much
we are-
blood is carried by IVC? Two-third blood. So if you remove IVC cannula, your oxygenator volume will suddenly decrease. But what is the advantage of removing IVC first? IVC purse string afterwards
If
is
any
difficult
bleeds
to see.
repair.
So you can ligate it properly on
Pump,
bypass.
Some said that we will remove SVC first.
Some remove SVC first.
What is the?
I remove SVC first.
Okay, why do you remove SVC first?
Because IVC carries the major amount of blood.
And if you have done direct SVC cannulation, you don't want to keep the big cannula in the
SVC.
because brain.
Okay. Last row, those are quiet. We are concentrating. Poor chaps, they are objecting that nobody is looking at us. Yes, madam, you. Protamine shock, how will you manage? Which year student?
Final year, sir.
From which part of the country?
From Hyderabad. Sir.
Hyderabad,
Yes, sir.
very good.
I will ask the anesthetist to give slowly the.
Ask anesthetist. Sir, object, my lord. You will ask anesthetist to do.
No,
Anesthetists have done it. They have given steroids, they have given test dose, they have kept calcium, done everything. What else you will do? This is an absolutely practical problem.
Patient is crashing.
Patient is quickly, BP is coming down. Rate slowing, 69.
50.
Sorry, you will not ask the perfusist to give volume. Giving volume. So who is going to answer that? Okay. So drugs by anesthetist. Number 2, volume by the perfusist. That's why you keep the arterial line. Now protamine has been given. Prasanna is saying go back on bypass. Protamine has been given 43%. Dr. Muralidhar calculates a special machine which tells you 43.1, 43.7 like that. Now what you do? How much heparin to give? You can answer. You can also answer. All your 3 can answer. You had a good sleep. He's पूरा stretch body भी stretch कर रहा है. Body stretch कभी कर रहा है. Quickly, madam. Crashing. जल्दी बोलो, कुछ बोलो. हिंदी होना, थोड़ा होना. हैदराबाद के बात करते तो हिंदी नहीं बात करते. बोलो. Always err on the side of giving full dose of heparin. Sir, correct? So don't try to bother. I have given only 20%. I have given only. Give full dose of heparin. It was an ASD. How many venous cannulae will be required to go back on bypass?
2.
This going on bypass is for what? To support the circulation. So for supporting circulation, how many cannulae are required?
Only
1 arterial
and 1
venous. So how many cannulae are required? 2. So you are tied both the purse string. So where will you take purse string now?
RA appendage.
His prompting you could hear. Great. RA appendage. And you have got 2 cannulae. So you quickly put one of it. And what will you do to the other cannula? उसको सोचने दो ना. उसका टेम्पोरोपैराइटल लोब नहीं चल रहा है. Never used to work such a long period. Which institution in Hyderabad?
NIMS.
अभी फोन करता है. नहीं कुमार गया, रिटायर हो गया. Amrish, right now. Video shooting. You put a clamp on the opposite venous line and go back on bypass. Okay? Remember this. So then sir will tell you variety of techniques to avoid repeat protamine shock. Understand? Sir, what you will do? Repeat protamine shock. Arterial protamine. Arterial protamine. You can give repeat test dose. Heavy dose of steroids you can give.
Steroids.
Arterial protamine you can give.
Anaphylaxis. You have to think of it if the PA is tense or if the patient has a empty PA and an empty heart when you're doing, and a empty PA or a distended PA. If the PA is tense, you should think of a catastrophic pulmonary hypertension. So treat it accordingly with pulmonary vasodilators and other things. But if it is empty, sloshy heart, you have to think of anaphylactoid or anaphylaxis.
Why does the reaction occur? How does it occur? How does this protamine reaction occur? Then you can answer these questions. What causes this reaction? If you answer that question.
You said final year, no? You must know at least some headings.
What are the types of protamine reaction?
4 types.
Fantastic.
4 types.
I was supposed to tell you that story. Huh?
Yeah.
4 types, 5 types. Just remind me, no, not now. Now we have to.
3 types, sir. Type 1, type 2A, 2B, and
best
3.
thing is never tell number. Just go on talking. Because I know only 2. And if you tell only 1, then you fail. So tell me causes. 1 is anaphylaxis. Number 2. You said no?
Anaphylactide and
See?
Now we are in.
Now, so who is in trouble?
And actually, I gave you one of the causes. I mentioned it.
Sir, Kanchi tells me that in the last 30 years, he has not seen a protamine shock.
He's great.
Your comment.
He's great. No, I'm not joking. He's really great. But in a teaching institute like us, in a government hospital, the anesthetists rotate every 3 months, every month, every 2 months.
So
And
whether it is related to the anesthetic
all
or
sorts
the-
of responsibility, like test dose being given, steroid being given. So all those things he must be doing extremely regularly. So
Speed of giving it, that people may give it very rapidly.
So
yeah, when it is given very
It has to be diluted in 50 to 100 ml of normal saline and given over 10 minutes. And then it should be given in peripheral line, not in the central line. And you may give steroids before you actually administer
So
it.
others may not be doing it. So you cannot say that. So I also had no mortality in transplant. Do you know?
And we used to believe in those days that if the patient had vasectomy, the chances of reaction was high.
Okay. Patient shifted. What patient you want to be operated? MVR. Patient shifted and within 10 minutes, somebody tells you, Sarjeet, jara dekhiye, blood coming quickly. By the time you are shifting, what are the thoughts in your mind?
So first would be the surgical cause of bleed. We might have.
First, second, third, fourth, fifth, 10th, cause surgical. Always treat everything as you are responsible. Okay? I'm talking about bleeding, which is coming continuously.
Our suture line might have given.
Sorry?
Suture line might have given away.
Suture line giving up. What?
Then second.
Suture line, first strings.
Yes, sir. The color of blood will dictate where might.
large amount of black.
Examiner want that cause.
Yes.
AV groove
Rupture.
Okay. So give it to person. Tension hai usko. Patient massively bleeding. What thoughts come to your mind for going on bypass?
Yes, bleeding.
You can combine, help each other.
Okay.
You can prompt them. No problem.
It is bleeding very badly.
Badly bleeding. He has told you, put me Vega, arrange the pump. What thoughts in your mind?
The tamponade, sir.
Sorry?
That's bleeding, severe. Okay. Okay, sir.
Okay. Yes, sir.
For that you require oxygenator.
Yes, sir.
So what in your mind? What can you do?
Stand by for that. So arrange that things.
There is no volume in patient's body. You have to volume the oxygenator extra. Number two, whatever volume in the patient's body is what hemoglobin? Normal or low? Low. So what should be his prime? Blood prime. Understand? So suppose normally for an adult patient, he puts only or no blood. So now it won't be like that. So his number one problem is volume. Number two problem is hemoglobin. So two things he has to be very particular about priming. Okay? That still we have got time or 1 minute. Problems associated with your Manpreet ka jaisa ho gaya ekdam. 5 minutes, sir. मनप्रीत कितना मिनट बाकी है? मनप्रीत गुस्से में गई है. Okay, last question. Problems associated with multiple cardioplegias.
Some long surgery.
Hemolysis. Multiple cardioplegias. Hyperkalemia. 1. 2. Myocardial edema. But you have to give cardioplegia, na? Surgery chal rahi hai. He's MVR, man. He's MVR 200 minutes. Related to cardioplegia, hyperkalemia. What else? Anemia. Hemodilution. And when you say hemodilution, what things get diluted apart from RBCs? Proteins. Which proteins you are worried? Albumin. Why? Oncotic pressure. So second problem is of hemodilution is oncotic pressure.
How can you manage this? How do you manage it?
Then don't forget.
Anything else you can do? I don't want to give blood. I don't want to give blood. I don't want
Bol,
to
bol.
No, I don't want to give all that. Perfusion will do something.
Perfusionist do something. What you can do?
Albumin transfusion and
Sensitive here. It is cardioplegia.
There is no RBCs. How will you save? Arre,
Cough at that time.
muff, cuff, puff, tough, sub. You should have. Anyway, thank you very much. Now, sorry saying any question you want to ask. Nahin? Thank you. Not for asking.